So we're starting with high yield facts and psychiatry. Okay, it goes from 586 up to 622. All right. Childhood and adolescent disorders. Attention deficit hyperactivity disorder (ADHD), a persistent pattern of excessive inattention and/or hyperactivity, impulsivity. Typically presents between 3 and 13 years of age, more common in males, often shows a familial relationship. History and physical examination in ADHD presents with core symptoms that can be divided into the following two categories: inattention and hyperactivity or impulsivity. Inattention exhibits a poor short attention span in schoolwork, play, displays poor attention to detail or careless mistakes, has difficulty following instructions or finishing tasks, is forgetful and easily distracted. Hyperactivity, impulsivity, fidgets, leaves seat in classroom, runs around inappropriately, cannot play quietly, talks excessively, does not wait for their turn, interrupts others. Okay. Diagnosis. Okay, so there's nothing about. Okay. Diagnosis. Symptoms must be present and cause an impairment in functioning for more than six or more months in at least two independent settings, home and school. Age less than 17 years. Diagnosis requires six or more symptoms from either category of core symptoms. Okay, so that is inattention and hyperactivity. So six or more symptoms. Okay, from either categories of core symptoms, intention and/or hyperactivity, impulsivity. Age 17 or more years. Diagnosis requires five or more symptoms from either category of core symptoms. Symptoms must be present before 12 years of age. Alternative case causes of inattention and/or hyperactivity must be considered, such as substance abuse, organic reasons, for example, lead toxicity, hearing visual impairment, thyroid disorder, sleep disorder, and absence seizures. Okay. So symptoms must be present before 12 years of age. Alternative cause of inattention must be considered. Okay. Treatment 4 to 5 years of age. Best initial treatment behavior therapy. The physician can add medication if behavior do not improve. 6 years of age or older. Best initial treatment. Pharmacologic therapy. Behavior therapy. First line, CNS stimulants, for example, methylphenidate, dextroamphetamine, amphetamine salts, dextroamphetamine, and amphetamine combo. Okay. Adverse effects: um, weight loss. Okay. Weight loss, decrease in appetite, insomnia, anxiety, irritability, headache, tic exacerbation, and decreased growth velocity. Normalizes when medication is stopped. Okay. Okay. Um, because of stimulants' potential for causing weight loss, it is recommended to give them after meals. Alternatives: non-stimulants, atomoxetine, norepinephrine reuptake inhibitor, second line treatment, can be tried first because of the negative side effect profile of CNS stimulants. Okay, so NERI. Okay. Second line treatment can be tried first because of negative side effects profile of CNS stimulants. Third line treatment, clonidine and guanfacine, alpha 2 agonist, bupropio- bupropion, and tricyclic antidepressants. All ages. Continuation of regular diet, sugar, and food additives are not considered etiologic factors. Okay. Key fact: use of stimulants is contraindicated for individuals with illicit substance abuse, at risk for addiction, and those whose legal guardian is against their use. Okay. Key fact: children must exhibit ADHD symptoms in two or more settings, for example, home and school. So the way I remember this from step one is, for someone who has ADHD, they crave stimulus. right? And what the medication, the stimulants, CNS stimulants provide is that stimulus. So the body then stops craving it and then, controls the symptoms that way. Autism spectrum disorder. Developmental disorder characterized by impairments in two major domains: one, social interaction and communication, and two, repetitive restrictive behavior, interests, and or activities. Autism spectrum disorder ASD is more common in males. Severity is based on the level of support required for each domain. The Diagnostic and Statistical Manual of Mental Disorders, DSM 5, does not distinguish among the pervasive developmental disorders. History and physical examination, deficits in social interaction and communication, reduced interest in socialization, reduced empathy, inability to form relationships, impaired language development, inability to understand social cues, poor eye contact. Prognosis is best determined by language development because its development is based on social interaction. Okay. Restricted and repetitive pattern of behavior, interests, or activities, highly fixated or restricted interests, inflexibility to change, hand flapping, or other stereotypes, increased decreased response to sensory input, for example, indifference to temperature, excessive touching, smelling, adverse response to sounds. Okay. Um, Symptoms must impair function, for example, academic or social. Um, Symptoms must be present in the early developmental period, typically less than 3 years of age. Conditions that produce symptoms suggestive of ASD must be excluded. So, intellectual disability or global developmental delay, hearing impairment, ruled out with audiometry before making diagnosis, selective mutism, refusal to speak only in social situations, Rett syndrome, similar to ASD, X-linked disorder characterized by marked physical and psychomotor regression at approximately 6 months of age after normal development, predominantly seen in females. Patients have classic hand wringing movements. Fragile X syndrome. Rett syndrome, it only happens in female. If it was in males, then males don't make it through the development stage, right? I believe. Uh, Fragile X syndrome, X-linked dominant disorder caused by hypermethylation of FMR1 gene, most common cause of inherited intellectual disability and autism. Presents with the following characteristics: macroorchidism, long face, prominent jaw, and forehead, high arched palate, large and everted ears, autism, connective tissue laxity, and or mitral valve prolapse. Okay. So, X-linked dominant disorder caused by hypermethylation of FMR1 gene, most common cause of inherited intellectual disability and autism. Treatment: intensive special education, behavioral management, specifically applied behavior analysis therapy, and symptom targeted medications, for example, stimulants or alpha 2 agonists for ADHD, neuroleptics for aggression and mood instability, selective serotonin reuptake inhibitors for stereotypical behavior, anxiety, and mood, family support and counseling, crucial component of treatment. Okay, did I miss a key fact up here? Key fact: children must exhibit ADHD symptoms in two or more settings. Okay. Key fact here: in patients with autism spectrum disorder, think about associated congenital conditions such as Rett syndrome, tuber- tuberous sclerosis, and Fragile X syndrome. Okay. Disruptive behavioral disorder, DBD. Okay. Includes conduct disorder, oppositional defiant disorder (ODD), and disruptive mood dysregulation disorder (DMDD). More common in males and in patients with a history of abuse. Psychiatric comorbidities are common, for example, post traumatic stress disorder or PTSD, uh, depression, substance abuse, somatoform conditions, and personality disorders. History and physical examination, ODD. Okay, so an oppositional defiant disorder, a pattern of negative, defiant, disobedient, and hostile behavior towards authority figures, for example, losing temper and arguing for 6 or more months, may progress to conduct disorder. Okay. So includes conduct and oppositional. So I believe oppositional one is before 18 years of age, and conduct is no, I said that the other way. Hold on, they explain it here. So, conduct disorder, a repetitive, persistent pattern of violating the basic rights of others or age appropriate societal norms, rules for 1 or more years in children less than 18 years. Okay, so conduct is the one that's less, happens in 18 years or less. Okay, behavior can be aggressive, for example, rape, robbery, animal cruelty, or non aggressive, for example, destruction of property, stealing, lying, running away, and truancy. So this is basically anything that will get them in trouble with the law, right? Um, After 18 years of age, conduct disorder is considered antisocial personality disorder. Okay, there you go. Okay, so the difference between conduct disorder and ODD is that in ODD, it's nothing that will get them in trouble with the law, whereas in conduct disorder, it's something that will get them in trouble with the law. Okay, so it will get them in trouble with like the uh, teachers and principals and stuff like that, but not with the law. Whereas in conduct disorder, if you think about it, it's going to be if an adult was doing it or anyone was doing it, it's like cops are going to be called on them, right? You're not going to call cops on a kid losing temper or arguing. Okay. Um, so after 18 years of age, conduct disorder is considered antisocial personality disorder. Okay, so after 18 years, it's called antisocial personality disorder. DMDD, that was disruptive mood dysregulation disorder. Okay, so what is that? It's a pattern of severe recurrent verbal, for example, screaming, or behavioral, for example, physical aggression outbursts that are out of proportion to situations, and persistently irritable or angry mood between outbursts. Symptoms must occur for 1 or more years. Uh, they may progress to depression in adulthood. DMDD should not be diagnosed before 6 years of age or after 18 years of age. Okay, so it should not be diagnosed before 6 years of age or after 18 years of age. Okay, so again, DMDD, a pattern of severe recurrent verbal, for example, screaming, or behavioral, for example, physical aggression outbursts that are out of proportion to situation, and or persistently irritable or angry mood between outbursts. So symptoms must occur for 1 or more years. They may progress to depression in adulthood. DMDD should not be diagnosed before 6 years of age or after 18 years of age. A lot of these things overlap. Like this also sounds like displacement, similar to that as well. Um, but that is not a mood disorder. So okay. Key fact here is conduct disorder is diagnosed in children. Antisocial personality disorder is diagnosed in adults. Thanks for that tip. Treatment here for DMDD or disruptive behavioral disorders. Psychotherapy is the first line treatment for all disruptive behavioral disorders. Okay, intellectual developmental disorder or intellectual disability, disorder of cognitive, social, and practical functioning associated with male sex, chromosomal abnormalities, congenital infections, teratogens, including alcohol, illicit substances, and inborn errors of metabolism. Most often, no identifiable cause is found in most patients with intellectual disability. History and physical examination. Patients have deficiencies in multiple domains as follows: intellectual deficits, poor reasoning, problem solving, planning, and performance on standardized testing. Adaptive functioning deficits, poor hygiene, social functioning, activities of daily living. Okay. Onset during developmental period, um, less than 18 years of age. Severity of intellectual disability determined by level of support required to address impaired adaptive functioning. IQ cutoffs for severity are no longer used with the DSM-5. Mild, independent in ADLs, that is activities of daily living. So mild, which is independent in ADLs, moderate, some teaching and support for ADLs, and severe, significant support for ADLs. Profound, dependent on support for all ADLs. Okay, so activity of daily life, living. Okay. Differential diagnosis, specific learning disorder. Um, okay, so like reading, math, or writing skills that are significantly lower than expected for age and intelligence. Reading disorder is the most common. Okay, treatment here is primary prevention, educating the public about possible causes of intellectual disability, and providing optimal prenatal screening and care to pregnant patients. Treatment measures, family counseling and support, speech and language therapy, occupational physical therapy, behavioral intervention, educational assistance, and social skills training. Learning disorder, remedial therapy directed towards patients' deficiency. Here, key factor is Down syndrome, trisomy 21, the most common chromosomal cause of intellectual disability. Fetal alcohol syndrome, FAS, the most common preventable cause of intellectual disability. And Fragile X syndrome, the most common inherited form of intellectual disability. So again, fetal alcohol is the most preventable one for intellectual disability. Fragile X is the most inherited one, and Down syndrome is the most common chromosomal cause of intellectual disability. Cool, cool, cool. Thank you for that. Tourette syndrome. Okay, so Tourette syndrome, disorder characterized by both motor and vocal tics, more common in males, shows a genetic predisposition associated with ADHD, learning disorders, and obsessive compulsive disorder. Symptoms can be temporarily suppressed with effort of or exacerbated by stress and fatigue. Okay, so temporarily suppressed with effort or exacerbated by stress and fatigue associated with ADHD, learning disorders, and obsessive compulsive disorders. Okay, and happens in males. Both motor and vocal tics are characterized. Okay, characteristic. History and physical examination symptoms begin less than 18 years of age and cause social or occupational impairment. Diagnosis requires the following: multiple motor tics, for example, blinking, grimacing, one or more vocal tics, for example, grunting, uh, coprolalia, echolalia, um, throat clearing, coughing. Okay. Uh, Tics present for more than 1 year. Tics recurrent occurs many times per day and or nearly every day. Okay, so it has to be happening for more than 1 year. So you will get something like this, and it looks like it is Tourette's, but then they'll say that it has been happening for 2 to 3 months now. You cannot call it Tourette's in that case. It's you gotta look for something else like dystonia or something. Whatever other options is, you got to this is the first thing you cross out because it's there to confuse you. Treatment, best initial treatment of behavioral therapy, um, habit reversal therapy is most effective. Okay, so behavior therapy, habit reversal therapy is most effective. If behavioral therapy fails or tics are severe disabling, the next step is pharmacologic management. Antidopaminergic agents, dopamine depleting agents, for example, tetrabenazine, vesicular monoamine transporter or VMAT2 inhibitors, results in decreased uptake of monoamines. Preferred over dopamine blocking agents, does not cause tardive dyskinesia. Okay, dopamine blocking agents, antipsychotics, for example, flufenazine, risperidone, haloperidol, or pemazoid. For severe refractory tics, typical antipsychotics, for example, Helidol, Pimozide, alpha 2 agonists, for example, clonidine, guanfacine, less effective at tick reduction, more favorable side effect profile. Okay. Um, Differential diagnosis. Um, Persistent chronic tic disorder consisting of either motor or vocal tics, but not both, which lasts more than 1 year. Key fact here is coprolalia. This is repetition of obscene words, and echolalia is repetition of words spoken by others. So it has echo in it. Okay, so that word helps. And C for cursing. Okay, if that helps. Separation anxiety disorder. Give me a sec. All right. Separation anxiety disorder. Disorder characterized by fear of separation from an attachment figure, for example, parent or home. Separation anxiety normally begins at about 1 year of age and peaks at 18 months. Considered pathologic if it becomes extreme or persists. May be precipitated by a stressful event. History and physical examination. Fear of separation from an attachment figure or home lasting for 4 or more weeks in children or 6 months or more in adults. May present as complaints of somatic symptoms to avoid school or work. Okay, so avoid school. Okay, diagnosis. So in fear of attachment fear, 4 weeks in children. Okay, so 4 weeks or more in children and 6 months in adults. Okay. Diagnosis. Excessive fear of separation from. Hold on, just a sec. So separating anxiety normally begins at 1 year of age, okay, and peaks at 18 and 4 weeks or more and 6 months, okay. Diagnosis: excessive fear of separation from attachment figures, and three of the following: separation that leads to extreme distress, separation that leads to social, academic, or occupational dysfunction, excessive worry about losing attachment figure, reluctance to leave home, sleep alone, or be alone, nightmares of separation, physical symptoms, for example, a stomachache when separated. Treatment: cognitive behavioral therapy, CBT, family therapy, SSRIs as an adjunct to therapy. Psychotic disorders, schizophrenia. All right. Every time I read schizophrenia or all of these, it reminds me of this meme someone posted on Reddit. Schizoaffective disorder, schizo personality disorder, schizophrenia, schizophreniform disorder, schizotypal personality disorder. They all look the same. It's funny. All right, moving on. So schizophrenia, disorder of thought process characterized by psychotic symptoms that are further divided into positive symptoms, hallucination, delusions, disorganized thought, behavior, and negative symptoms, flat affect, social withdrawal, and apathy. Okay. Epidemiology. Prevalence is approximately 1%. Males more than in females. Peak onset is earlier in males, 18 to 25 years of age, than in females, 25 to 35 years of age. Schizophrenia is first degree relative, increases risk. Up to 50% of patients attempt suicide. 10% of patients with schizophrenia complete suicide. Etiology unknown. Theories focus on neurotransmitter abnormalities such as dopamine dysregulation, frontal hypoactivity, and limbic hyperactivity, and abnormal brain abnormalities on CT and MRI, enlarged ventricles, and decreased cortical volume. Key fact here is psychosis, hallucination, and or disillusion without insight does not equal to schizophrenia. Differential diagnosis must also include organic disease, other psychiatric illnesses, and substance-induced psychosis. Okay. History and physical examination. Schizophrenia presents with chronic or recurrent psychosis, disorganization, and or um, negative symptom, cognitive impairment in multiple areas. For example, processing speed, working memory, attention, social cognition, may be present. Mood and anxiety symptoms are common. So, how do you diagnose this? Diagnosis requires 2 or more of the following symptoms for 6 or more months with social and occupational dysfunction. At least one of the symptoms must be hallucination, delusion, or disorganized speech. Okay, so it could be that they don't have hallucination or delusions, but they have disorganized speech. Okay, so that it can still be considered um, schizophrenia. Okay, so the things you need is hallucination, delusion, or disorganized speech, one of these, and two of these, right? Disorganized or catatonic behavior, negative symptoms, flattened affect, social withdrawal, anhedonia, anhedonia, apathy, decrease in emotion, may mimic depression. Okay, so 5 A's of schizophrenia diagnosis: a flat affect, evolution, uh, asociality, anhedonia, and apathy. Okay, so anhedonia is the one where you don't feel pleasure in doing stuff. Okay, uh, okay, so requires 2 or more of the following symptoms for 6 months or more: social or occupational dysfunction. At least one of the symptoms must be these. Okay, so you only need 2 of these, not 3. Sorry about that. And one of those 2 or more needs to be from hallucination, delusion, or disorganized speech, and the others could be any of these: disorganized or catatonic behavior, or negative symptoms. Negative symptoms consist of flattened affect, social withdrawal, anhedonia, apathy, decrease in emotion, or may mimic depression. Here, the timeline is important. That has to be 6 months or more. Okay. If it's less than 6 months, it's something else, and if it's more than a year, it's something else, and something like that, right? So it has to be 6 months or more for this to be schizophrenia diagnosis. Okay. Schizophreniform, disorganized or thought process. Okay. So disorder, sorry, not disorganized. Disorder of the. Do I have schizophreniform right now? Okay, disorder of thought process. Presentation similar to schizophrenia, but psychotic symptoms are present from 1 to 6 months only. So there you go. So if it's between 1 to 6 months, it's schizophrenia, phreniform, and if it's more than 6 months, so 6 months or more, then it's schizophrenia. Okay. So see this table for the differential diagnosis of psychosis. Okay. So prognosis. Better prognosis: acute onset with positive manifestations, hallucinations, and delusions, no family history, rapid symptom resolution with treatment initiation. Poor prognosis consists of symptoms arise before 13 years of age, insidious course with depressive states, developmental delay, timid, introverted, and uncommunicative before manifesting symptoms. Okay. Treatment here is it is usually lifelong and often involves a combination of medication, psychotherapy, social skill training, and coordinated specialty care services. Okay, specialty care services. Pharmacologic intervention with antipsychotic medications can be used to treat the acute symptoms of psychosis as well as for long term management and prevention of symptoms. See this table down here. Okay. So before that, let's go through the key facts. In addition to psychotic symptoms, a patient must have mood symptoms present the majority of the time for physician to differentiate schizoaffective disorder from schizophrenia. Okay. Okay. Psychotic. In addition to psychotic symptoms, a patient must have mood symptoms. Okay. So schizoaffective disorder, I believe it was schizoaffected by depression or mood disorder. Okay. So it's the one with where you have symptoms of schizophrenia, but then there's also MDD that they have. I think I don't want to confuse myself and you guys, so uh, we'll do that when we cover schizoaffective disorder. Key fact: terms used to describe components of psychosis are as follows: delusion, a fixed, false, idiosyncratic belief. Okay. So what is psychosis basically? So delusion, hallucination, perception without an existing external stimulus, or illusion. This is perception of an actual external stimulus. Okay. Another key fact: in those with poor medication adherence or non-compliance, depot or injectable is preferred uh, because they are longer acting medications. Another key fact: atypical antipsychotics, olan, olanaz, olanzapine, risperidone, quidapine, are preferred to typical antipsychotics. Haloperidol, thioridazine, chlorpromazine, given fewer EPSs and anticholinergic effects. Another key fact: resistance is considered when a minimum of two drugs have been attempted previously without improvement of symptoms. Okay, so resistance is considered when a minimum of two drugs have been attempted previously without improvement of symptoms. Okay, so uh, atypical antipsychotics are preferred to typical antipsychotics given fewer EPSs and anticholinergic effects. Correct. Okay. So we have a question here. A 24-year-old woman presents to the clinic. She has been hearing voices and has isolated herself from her friends and family. She first noticed the voices about 2 months ago when she was feeling sad and reported sleeping poorly. She reports that her mood has since improved and denies any current sleep disturbances but is still hearing voices. What is her most likely diagnosis? Okay. So this is not schizophrenia. That's first thing that you need to know because it's only been 2 months. Okay. Um, and yeah, then we gotta go through this basically. Okay. It For it to be brief psychotic effect, it needs to be 1 day to 1 month. Okay. Uh, Schizophrenia form, it has to be between 1 to 6. So this most likely fits this, right? Um, for schizoaffective disorders, okay, so it's schizoaffective disorder with mood disorder. So I was right. Okay. The way I remember is schizoaffected by mood disorders. Okay. Requires history and presence of psychosis plus mood episodes and psychosis for 2 weeks or more without mood episodes. Okay. That's a little stuff. So let's go through that again. So she's hearing voices. Okay. So hallucinates, auditory hallucination, and has isolated herself from her family and friends. Okay. She first noticed the voices 2 months ago, feeling sad. Okay, so that's depressed, and reports sleeping poorly. Okay, so there's also change in that. She reports that her mood has improved and denies any current sleep disturbances, but is still hearing the voices. What is her most likely diagnosis? So I'm between these two. So let's see. So it is schizoaffective. This patient most likely has schizoaffective disorder, which is characterized by psychosis and intermittent mood symptoms. Okay, the diagnosis requires one, psychotic symptoms and mood symptoms, and two, at least 2 weeks when psychotic symptoms are present without mood symptoms. Okay, uh, so that is okay. That's what they mean. So that is important. Uh, so there has to be a 2 week gap or window when there is no mood symptoms there. Okay. Uh, Patient often have chronic psychotic symptoms even after mood symptoms have resolved. Okay. This is in contrast to bipolar disorder, where once the mood disorder subsides, the psychosis also subsides along with it. Okay. So again, hearing voices. She noticed the voice 2 months ago when she was feeling sad and reported sleeping poorly. But since then, for 2 months, she has not. She has improved in sleep. Okay, and but the voices is still there. So voices consists of psychosis, which is hallucination perception without an external stimulus. Right. So there's that. All right, so let's go through this chart. Differential diagnosis of psychosis, disorder, and duration characteristics. Psychotic disorder. Brief psychotic disorder, 1 day to 1 month. Okay. If it's more than 1 month, it cannot be considered brief psychotic disorder. Schizophreniform, it's 1 month to 6 months. Okay. So this comes first, then comes schizophreniform. So note, both present similarly to schizophrenia, but are differentiated by duration of illness, can be preceded by stressors, are less likely to have negative symptoms, and have a better lifetime prognosis than schizophrenia. Schizophrenia, more than 6 months, okay? And schizoaffective disorder is psychosis with mood disorders, mania, or depression. Requires history, presence of psychosis plus mood episodes, and so you need these two requirements to fulfill schizoaffective disorder diagnosis. Psychosis plus mood episode, and psychosis for 2 or more weeks without the mood episodes. Okay, and mood episodes doesn't have to be depression. Okay, it could be mania, where they're spontaneously going on international trips, shopping, buying stuff and shopping, and whatever is like out of it's not usual for them basically to do. Okay, so personality disorder, um, schizotypal, magical thinkings. Okay, so schizotypal, they're like the ones that are into crystal balls and all that stuff. So magical thinking is just that they're sort of eccentric, right? Schizoid, it's loners. Okay, they schizoid. The way I remember that is zoid as a shape. So I put the shape into in my head. It's like a wall. So they surround themselves in that wall. Okay, so schizoid is like they're in that basically wall type thing. So they like to be alone. It's not that uh, they're scared of rejection or anything like that. That's why they're alone. It's just they prefer being alone. So like the lone wolf type people. Little Twilight reference there. Delusion disorder. Persistent delusions, often non-bizarre, without disorganized thought process, hallucinations, or negative symptoms of schizophrenia. Subtypes are jealous, paranoid, somatic, erotomatic, or grandiose. Okay. So all of these are delusional, um, considered delusions. Okay. So persistent delusions, often non-bizarre, without disorganized thought process. So hallucinations or negative symptoms of schizophrenia. Okay. So without the apathy and hedonia and all that stuff. Right? Where to go? So flattened effect, social withdrawal, anhedonia, apathy. All of these stuff don't exist. Okay, in that case, it's considered persistent delusions. Okay, so persistent delusions, often non-bizarre, without disorganized thought process, hallucinations, or negative symptoms of schizophrenia. Subtypes are jealous, paranoid, somatic, uh, erotomanic, or grandiose. Okay, grandiose is one where they have feeling of them being bigger than everyone else, like grander, or more successful, stuff like that. uh Jealous, it's one where you know they're jealous of their partner speaking to someone else, or someone they're crushing on speaking to someone else. Paranoid, paranoid is just they're always suspicious of things, like they think their phone is being tapped by the government. Somatic, I gotta look that up. And erotomanic. All right, so erotomania is when you think someone is in love with you, but they're not. Okay, and somatic delusion, it's fear of infestation or infection. Okay. All right, so moving on. Symptoms must be present 1 month or more. Okay. Day-to-day functioning is mostly unaffected. Uh, fully ado. Um, definitely butchering that pronunciation. A shared delusion. Commonly between parent and child. The best course of action is to separate the patient pair and treat individually. Okay, so a shared delusion. So yeah, a lot of documentaries about that on Netflix. Antipsychotic medication. So yeah, I feel like we need to know that. Whatever this French stuff is. Folie à deux. Deux. Okay. Antipsychotic medications. Drug class, mechanism, examples, indication, and adverse effects. Okay. Typical antipsychotics. Mechanism is D2 antagonist, which is high potency. Uh, Example is haloperidol, flufenazine. Uh, Indication here is psychotic disorder, acute agitation, acute mania, Tourette syndrome, thought to be more effective for positive symptoms of schizophrenia. If compliance is a major issue, the physician can consider antipsychotics available in long-acting depot form. Okay. Okay. So typical antipsychotics. Okay. So we use that in psychotic disorder, acute agitation, acute mania, Tourette syndrome, thought to be more effective for positive symptoms of schizophrenia. If compliance is a major issue, the physician can consider antipsychotics available in long-acting depot form. Okay. EPS. See this table. EPS more common than anticholinergic symptoms, which is dry mouth, urinary retention, and constipation. Okay, QTC prolongation and torsade de points. Again, butchering the pronunciation there. Especially with IV haloperidol. Neuroleptic malignant syndrome. Okay. All right. D2 antagonists with low potency are thioridazine and chlorpromazine. Okay, so remember that. Same as high potency indications. Adverse effect, however, are more anticholinergic than EPSs. More sedating, greater risk for orthostatic hypotension. Thioridazine causes QTC prolongation and irreversible retinal pigmentation. Antipsychotics, D2 antagonists, 5H2 antagonists. Okay. So these are atypical ones. Examples are risperidone, quetiapine, olanzapine, paliperidone, paliperidone, ziprasidone, and clozapine. Okay. You should pause this and pronounce those by yourself, because again, I'm not good at pronouncing these. Indications: first line treatment for schizophrenia given fewer EPSs and anticholinergic effects. Clozapine is reserved for severe treatment resistance and severe tardive dyskinesia. Okay. So it's reserved for severe treatment resistance and severe tardive dyskinesia, clozapine. Okay. D2 partial agonist, 5-HT1A partial agonist. Okay. 5-HT2A antagonist. So example is aripiprazole. Okay. Same as other atypicals, except it does not cause hyperprolactinemia due to its ability to act as a D2 receptor agonist under hypodopaminergic conditions and as a D2 receptor antagonist during hyperdopaminergic conditions. Decrease in EPSs, that's extrapyramidal symptoms, due to 5-HT2A antagonism, weight gain, dyslipidemia, type 2 diabetes mellitus, somnolence, sedation, and QTC prolongation, and with ziprasidone. Okay. Hyperprolactinemia with risperidone. Clozapine can cause agranulocytosis, and that is an important one to remember. It require weekly CBC monitoring during first 6 months. Okay, so let's just go through the adverse effects because those are usually tested on. So extrapyramidal symptoms are more common than anticholinergic symptoms in typical antipsychotics. QTC prolongation and TDP, especially with haloperidol. Okay. Uh, Another one is anticholinergic are more common than EPSs with low potency D2 antagonists. Okay. Greater for orthostatic hypotension. Thioridazine causes QTC prolongation and irreversible retinal pigmentation. Typical antipsychotics are haloperidol and fluphenazine, and low potency one are uh, thioridazine and chlorpromazine. I believe Sketchy had a good mnemonic for this. It's like where hal was flu, high for high potency ones, haloperidol and fluphenazine, and thieves cheated and they're low or something like that. I forget. If you remember, you can comment down below. But just make a mnemonic for this so you remember which one's high, which one's low, and which ones are typical antipsychotics and which ones are atypical ones. And atypical ones, there are decreased amount of extrapyramidal symptoms due to 5-HT2A antagonism. Weight gain, dyslipidemia, type 2 diabetes, somnolence, and um, sedation and QTC prolongation. All of these with ziprasidone, or QTC, I guess, is with that. And hyperprolactinemia with risperidone. Okay. And with clozapine, the most important one, it's agranulocytosis that you'll see. Its use requires weekly CBC monitoring, okay, during the first 6 months at least, okay. So back to the treatment for schizophreniform. Okay, schizophrenia 1 to 6 months. Supportive psychotherapy, training in social skills, vocational rehabilitation, and illness education may help. In particular, family psychoeducation therapy decreases the risk for relapse. Negative symptoms may be more difficult to treat than positive symptoms. Atypical antipsychotics are the drug of choice. Catatonia, awkward posturing, mutism, and um, immobility may be seen in severe disease. This can be treated with benzodiazepine challenge and electroconvulsive therapy, ECT. Find a description of ECT in the major depressive disorder section later in this chapter. Will do, sir. Okay. Mnemonic. Evolution of extrapyramidal symptoms 4 and A. 4 hours, acute dystonia. 4 days, akinesis. 4 weeks, akathisia. And 4 months, tardive dyskinesia, often permanent. Okay, so these are extrapyramidal symptoms and treatment. Acute dystonia, prolonged, painful, tonic muscle contraction or spasm. For example, torticollis or oculogyris crisis. Okay. Time of onset is hours. Okay. So that's why 4 hours, acute dystonia. There you go. Treatment: anticholinergics, benztropine or diphenhydramine for acute therapy. Patients who are prone to dystonic reactions may need regular prophylactic dosing, for example, benztropine. Okay. Akathisia, that's subjective, objective restlessness that is perceived as being distressing. What? Okay, subjective, objective restlessness. Got it. That is perceived as being distressing. Okay, so they're restless, but it seems like that they're distressing. Let me Google this. All right, so introduction. Akathisia. So akathisia is defined as an inability to remain still. Okay. It is a neuropsychiatric syndrome that is associated with psychomotor restlessness. The individual with akathisia will generally experience an intense sensation of unease or inner restlessness that usually involves the lower extremities. Okay, so restless leg syndrome type thing going on there. Um, or when you're sitting in a chair and you constantly want to move about, or when you're sleeping on bed and you want to toss and turn, that sensation. It's what this is. Time of onset, weeks. Sorry. Decreased dose of treatment, decreased dose of neuroleptic, beta blockers, propranolol, benzodiazepine, lorazepam, or anticholinergics, benztropine. Okay, so 4 days is akinesia. Where that at? Okay, so I guess that's dyskinesia is not akinesia, right? Okay, so 4 days is akinesia, but 4 weeks is akathisia. Okay, dyskinesia, pseudo Parkinsonism. For example, tremor, shuffling gait, cogwheel rigidity. Time of onset is weeks as well. Decrease dose of neuroleptic or discontinue uh, if intolerated. Okay, so decrease dose of neuroleptic or discontinue if tolerated. Anticholinergics, benztropine, or dopamine agonist, amantadine. Uh, Tardive dyskinesia. Okay, so that's 4 months is tardive dyskinesia. No A there. Stereotypic involuntary painless oral facial movements, probably from dopamine receptor sensitization from chronic dopamine blockade, often irreversible, 50% of the time. Okay, it takes months for onset, and treatment is discontinue or decrease dose of neuroleptic, possibly change neuroleptics, for example, to clozapine or quidapine. Anticholinergics or decrease in neuroleptic dose may initially worsen tardive dyskinesia. If discontinuing or decrease neuroleptic dose is ineffective, try valbenazine, benazine, or deutetrabenazine. Okay. Okay. And cool. Okay. And then we have neuroleptic malignant syndrome, fever, muscle rigidity, autonomic instability, elevated creatine kinase, and white blood cells or delirium. Okay, it can happen anytime. Discontinue medication, provide supportive care in the intensive care unit, administer dentraline or bromocriptine. Okay, so this is fever, muscle rigidity, autonomic instability, elevated creatine kinase, okay, and white blood cell delirium. Okay. Let me grab the same page from first aid from step one. So these are the psychiatric emergencies. Serotonin syndrome, cause any drug that increases 5-HT. Psychiatric drugs like MAO inhibitors, SSRIs, SNRIs, TCAs, vilazodone, vortioxetine, buspirone. Okay, non-psychiatric drugs, tramadol, ondansetron, triptanes, linezolid, MDMA, dextrofen, methotrexate, meperidine, and St. John's wort. Okay. Serotonin syndrome, St. John's wort. So that is also a CYP440 inducer. Right. Manifestations, 3 A's. So increases in activity. Okay, neuromuscular, for example, clonus, hyperreflexia, hypertonia, tremor, seizures, autonomic instability, for example, hyperthermia, diaphoresis, diarrhea, altered mental status. Treatment is benzodiazepine and supportive care, cyproheptadine, 5-HT receptor agonist if no improvement. Prevention is avoid stimulus serotogenic drugs and allow a washout period between them. Okay, so MAO inhibitors, serotonin syndrome. Hypertensive crisis. Um, Eating tyramine-rich foods, for example, a cheese, cured meat, wine, chocolate, and while taking MAO inhibitors, insufficient washout period when switching antidepressants to or from MAO inhibitors. Manifestation, hypertensive crisis. Tyramine displaces other neurotransmitters, for example, NE in the synaptic cleft that increases sympathetic stimulation. A treatment here is phentylamine. Neuroleptic malignant syndrome. It's caused by antipsychotics, typical uh, more than atypical, and genetic predisposition. So manifestations is malignant fever. That is M for myoglobinuria. Okay, so that goes with the creatine kinase right here. Elevated CK. Okay. Fever, encephalopathy, vitals unstable, increase in enzymes, for example, CK. Muscle rigidity, and lead pipe. So lead pipe. Okay, so lead pipe. Treatment here is dantrolene and dopaminergics, for example, bromocriptine, emantadine, benzodiazepine, discontinue causative agents. Delirium tremens, that's alcohol withdrawal. We'll go over that in this chapter. Acute dystonia, typical antipsychotics, anticonvulsants, for example, carbamazepine, metoclopramide, sudden onset of mesospasm, stiffness, and or oculogyric crisis occurring hours to days after medication use can lead to laryngospasm requiring intubation. Treatment is benztropine and diphenhydramine. Okay, so there's a sudden onset of the suddenness, as Arnab Goswami says. The suddenness. Sudden onset of muscle spasms, stiffness, and or oculogyric crisis occurring hours to days after medication use. Okay, can lead to laryngospasm requiring intubation. Lithium toxicity, increase lithium dosage. It's caused by that, and decrease in renal elimination, for example, acute kidney injury. Medications affecting clearance, for example, ACE inhibitors, thiazide diuretics, and SAIDs, or yeah. Narrow therapeutic window. Nausea, vomiting, slurred speech, hyperreflexia, seizures, ataxia, and nephrogenic diabetes insipidus. Treatment is discontinue lithium, hydrate aggressively with isotonic sodium chloride, consider hemodialysis. Tricyclic antidepressant toxicity, TCA overdose. Okay. Um, Respiratory depression, hyperpyrexia, prolonged QT, tricyclics, CCC, so convulsion, coma, and cardiotoxicity, arrhythmia due to sodium channel inhibition. Treatment here is supportive treatment, monitor ECG, sodium bicarbonate prevents arrhythmia, and activated charcoal. Okay, so delirium tremens, alcohol withdrawal occurs 2 to 4 days after last drink, classically seen in hospital settings when inpatient cannot drink. So when it says 2 to 4 days, that is subjective. Okay. Manifestations, altered mental status, hallucinations, autonomic hyperactivity, anxiety, seizures, tremors, psychomotor agitation, insomnia, nausea. Treatment here is longer acting benzodiazepines. Okay, so we give benztropine here and diphenhydramine benzodiazepine for that, dantrolene and dopaminergics for this, phentylamine for hypertensive crisis, and benzodiazepine and this for serotonin syndrome. Okay. All right. Moving on to dissociative disorder. Includes dissociative identity disorder, depersonalization, derealization disorder, and dissociative amnesia. Symptoms are not better explained by substance use, another medical condition or another mental disorder. See this table for an overview of the dissociative disorder. Okay, so treatment here is best initial treatment, psychotherapy. Appropriate pharmacologic treatment, for example, SSRIs, can be added to address comorbidity, for example, depression, anxiety, substance abuse, or PTSD. Okay, and that was the end of the treatment. Okay, so overview of dissociative disorders. Disorder characteristics. Dissociative identity disorder, formerly multiple personality disorder. Okay, the split personality one. Uh, Characteristics. Presence of two or more distinct personalities or identities with separate memories and behavior patterns that dominate at different times. Patients are usually unaware of the other personalities and complain of frequent gaps in recall and memory lapses. Dissociative uh, identified disorder is dissociative identity, should be identity disorder, is more common in females, associated with history of trauma, child abuse, PTSD, borderline personality disorder, uh, somatic symptom disorder, and major depressive disorder. There's a great documentary by M. Night Shyamalan called Split about this disorder. Uh, I recommend it. Um, Depersonalization or derealization disorder. Recurrent or persistent experiences of one or more of the following. Okay, so depersonalization, feeling of detachment from one's body, actions, thoughts, and perceptions. Patient may feel like an outside observer or have out of the body experience. Okay, okay, so detachment of one's body, action, thoughts, and perception. Patient may feel, there should be a period there. Patient may feel like an outside observer or have out of the body experience. Okay, and derealization, that is experiencing one's surrounding as unreal. Okay. And still able to identify reality, has insight into the distinction between internal and external reality, unlike in patients with psychosis. Okay, so depersonalization, it's out of the body experience. Derealization is the surrounding is unreal. Okay. Dissociative amnesia, inability to recall memories or important personal information, usually after a traumatic or stressful event. Procedural memory is preserved. Dissociative fog, subtype of dissociative amnesia characterized by sudden, unexpected travel in a dissociated state and subsequent amnesia of the travel. Increased risk for suicide as amnesia resolves and memories of trauma return. Okay, so the A that they used over here, recurrent or persistent experience, that's transient. Depersonalization, derealization may occur during times of severe stress. This does not meet criteria, diagnostic criteria for DDD, the dissociative disorder, depersonalization disorder. That. Okay. Anxiety disorder. So generalized anxiety disorder, uh, which is like gifted to us as medical professionals. Generalized anxiety disorder, uncontrollable, excessive anxiety or worry about multiple topics that leads to significant impairment or distress. History and physical examination. Um, Clinical onset is usually in the early 20s when they decide to take on medical field. Generalized anxiety disorder is more common in females. That's sus. Uh, Diagnosis, cap right there. Diagnosis, generalized anxiety disorder is diagnosed when excessive anxiety or worry about multiple activities is experienced on most days for 6 months or more. Okay, so that's important, 6 months or more. How about 5 years? Symptoms of anxiety or more. Life. Symptoms of anxiety, worry, or I'm gonna cry inside. Okay, symptoms of anxiety, worry are associated with three or more somatic symptoms. Only one required in children: restlessness, easy fatigue, difficulty concentrating, irritability, muscle tension, sleep disturbances. Symptoms cause a clinically significant impairment, for example, social or occupational. Yep. Disturbances are not caused by substances. For example, drug of abuse, for example, cocaine, medications, for example, amphetamines. Okay, disturbance is not better explained by another psychiatric disorder, for example, excessive worry about panic attacks. Nope. No. It reminds me of the Hulk dialogue from Avengers, where he's like, "That's the secret cap. I'm always angry." That's the secret cap. I'm always anxious. Panic attack lasts for like 15 minutes. Okay. Treatment. Best initial treatment. First line psychotherapy. CBT, applied relaxation, biofeedback. Um, plus SSRIs. For example, fluoxetine, sertraline, uh, escitalopram, or SNRIs. For example, venlafaxine or duloxetine. Okay, see this table. I will. Alternative treatment, second line, buspirone, uh, TCAs, benzodiazepines, short-term treatment. So mnemonic: diagnosis of GAD in an adult requires the presence of three or more of the worry-wart syndrome, which is wound up, irritability, worn out, fatigue, absent-mindedness, difficulty concentrating, restlessness, tension in muscles, and sleep disturbances. Okay, so all of these. Uh, Key fact here is, like SSRIs, buspirone should not be used in conjunction with monoamine oxidase inhibitors. Okay, buspirone also causes weight loss along with reducing anxiety. Okay, panic disorder. Okay, so should not be used in conjunction with monoamine oxidase inhibitor. Okay, panic disorder characterized by recurrent, unexpected period of intense fear that lasts for several minutes and causes excessive worry about having another panic attack. History and physical examination. Recurrent episodes of intense fear and discomfort. Symptoms usually last less than 30 minutes. So basically, they feel like they're having a heart attack or something. They have their attack and they call up the ambulance, but by the time ambulance gets there, everything is normal. Like they have normal vitals, normal uh, you know, they don't look as distressed anymore, um, or hyperventilating or anything like that, right? So that is what panic attack looks like. Okay, so recurrent episodes of intense fear and discomfort. Symptoms usually last less than 30 minutes, associated with agoraphobia, increased risk of suicide, more common in females, may occur at any age. There is a strong genetic disposition. Okay. Anxiolytic medications, drug class indications, and adverse effects. SSRIs, for example, fluoxetine, sertraline, paroxetine, citalopram, and escitalopram. Okay. First line treatment for generalized anxiety disorder, OCD, and panic disorder, and nausea, GI upset, somnolence, sexual dysfunction, agitation. SNRIs, for example, venlafaxine, duloxetine. First line treatment for GAD. Okay, again, hypertension and stimulant effects. 5-HT partial agonists, for example, buspirone, that is, or buspirone. Second line treatment for generalized anxiety disorder, social phobia. Okay. Okay, so okay. Used if sexual dysfunction experienced with SSRIs. Okay, so gotta remember these. Okay. Adverse effect: headaches, dizziness, nausea, no tolerance, dependence, or withdrawal. Beta blocker, propranolol. Indication: performance only social anxiety disorder. Adverse effects: uh, bradycardia, hypertension. Benzodiazepines, for example, clonazepam, alprazolam. Okay. Indication: anxiety, shortness, short term. Okay. We can't give benzos for too long. Insomnia, alcohol withdrawal, muscle spasms, night terrors, and sleepwalking. So these are the indications. Um, okay, so adverse effect here is increased sleep duration, risk for abuse, tolerance and dependence, and disinhibition in young or older patients, confusion. Abruptly stopping a short-acting benzodiazepine, for example, alprazolam, can result in seizures. Okay, GAD, generalized anxiety disorder, GI, gastrointestinal, OCD, obsessive compulsive disorder. Okay. Key fact here is differential diagnosis of panic disorder. Medical condition: angina, medical infarction, myocardial infarction, arrhythmia, hyperthyroidism, pheochromocytoma, hypoglycemia, psychiatric conditions, substance-induced anxiety, GAD, PTSD. Okay, so panic disorder is this. So let's go through that. We're still on panic disorder. So diagnosis: panic attack, discrete periods of intense fear or discomfort in which four or more of the following symptoms develop abruptly and peak within 10 minutes. Tachycardia or palpitations, diaphoresis, chest pain, shortness of breath, nausea, trembling, dizziness, fear of dying or going crazy, depersonalization, hot flashes, chills or heat sensation, paresthesia, increased sensitivity to lactate infusion, which may precipitate an attack and the susceptible. So what is panic disorder? This is recurrent unexpected panic attacks, attacks followed by 1 or more months of at least one of the following: persistent worry, concern of having additional attacks, maladaptive change in behavior, for example, avoidance of unfamiliar situation, worry about consequences of attack, for example, losing control, no explained by not explained by substance, medication, or another medical condition. Okay, so in disorder, it happens more than once, basically, with 1 month gap. Okay, with 1 month of at least one of the following. Oh, okay, never mind. So with 1 month of this, so person worry, or they're worried that they have some kind of condition or illness that gives them an that attack, or they're in some kind of situation which scares them. Um, okay, I guess. I think I'm just making words. So yeah, this is pretty straightforward. It's easy to pick out from the options. Okay, so medical conditions you gotta differentiate with is angina. Okay, so angina, it doesn't last only for less than 15 minutes. It lasts longer. It can happen. It does happen during resting, right? However, with angina, you have a history of more things. Okay. Where it doesn't happen because of worrying about something, basically. It can happen while they're watching TV or whatever, and they're chilling. Okay. Myocardial infarction. What's the difference between these? MI, it's gonna cause chest pain. They will have a history, of cholesterol or something like that. Okay, again, it's not that they're worried. It just comes up because of the lifestyle that they have. Arrhythmias can be spontaneous. Um, but again, with panic disorder, they'll give you a history, right? That um, one of these things. Worry about consequence of attack, or they're worried that they have some kind of illness or something like that. Okay, hyperthyroidism, again, it comes with an array of symptoms. Pheochromocytomas. So hyperthyroidism is only the palpitation one that might sound similar to panic disorder. Other than that, all the other ones don't come with panic disorder. Pheochromocytoma, it's again, catecholamine surge, right? So agitation, not agitation, but like you'll have palpitation, but you'll have other, uh, you know, symptoms that come with pheochromocytoma that I'm skipping on right now. I just remembered that it's because of a tumor in medulla in their adrenals. Epinephrine and norepinephrine surge, and all the things that causes, basically. And hypoglycemia. Hypoglycemia is iffy because hypoglycemia causes like drunken state, right? So it's like the person is drunk. Um, that's what that looks like. Psychiatric condition, substance induced anxiety. Okay. So here it cannot be explained by substance, all of these things. Okay. And GAD, we already talked about that. They got to be worrying about more than one thing here. So more than two or more things, right? And PTSD, that is caused by trauma. So that there is a specific trigger for this. Okay. And there's a specific traumatic history for that. So that's how you differentiate with panic disorder, I guess. Treatment. See table this for medications. Acute initial treatment, benzodiazepine, for example, clonazepam. Long-term use should be avoided due to concern of potential dependence of and abuse. Benzodiazepines should be tapered as long as long-term treatment is effective. Okay. Long-term treatment is SSRIs, for example, sertraline. Sertraline, yeah. Psychotherapy, CBT, high rates of response and sustained effects compared with placebo and pharmacotherapy alone. Phobias, okay. Social and specific. So disorder characterized by excessive fear that is unreasonable and stimulated by the presence of anticipation of a specific object or situation. Patients recognize the fear is excessive. Symptoms are persistent, usually lasting 6 or more months. History and physical examination. Social anxiety disorder presents with excessive fear of criticism, humiliation, and embarrassment in multiple situations requiring social interaction. Patients may have anxiety in anticipation of the event, palpitations and sweating during the event, and they may avoid triggers, for example, social events, parties, or school. Okay, performance only subtypes, symptoms provoked only by performance situations, for example, public speaking, test taking, or sexual intercourse. Uh, Remember Superbad? Good movie. Um, Specific phobia, excessive anxiety and fear provoked by exposure to a feared object or situation, for example, animals, heights, airplanes. Most cases begin in childhood. And agoraphobia, this is fear, anxiety of developing panic-like symptoms in two or more situations from which it may be difficult to escape or get help, like being in a bus or an elevator. Resulting in avoidance of those situations. Patients may become completely confined to the home. Agoraphobia is associated with panic disorder. So agoraphobia is defined as fear of being alone in public spaces. Literally translated, it means fear of the marketplace. Okay. Oh wait, what I said was claustrophobic. Claustrophobia, sorry. Okay. So this is fear of the marketplace. Okay. Being in public places. Treatment here, social anxiety disorder. Both CBT and SSRIs are first line, and the choice of treatment is dependent on patient preference. CBT involves desensitization through incremental exposure to the feared object or situations along with relaxation techniques. Second line treatment includes benzodiazepines if no history of substance use disorder, or phenylazine if patient has a history of or risk factors for substance use disorder. Performance only subtype, first line treatment with beta blockers, for example, propranolol, before the event or as needed. Second line treatment includes CBT, benzodiazepine, and or SSRI specific phobia. First line treatment is CBT. Second line treatment includes SSRIs, uh, benzodiazepines, and acrophobia, CBT, and SSRIs. So mostly uh, CBT is like what's used for any type of anxiety or phobias. Essentially, if that's an option, that's the one you would want to pick. And if that's not there, then SSRI would be a good guess if you can't remember the first line for these. Key fact: in patients with a history of substance abuse, benzodiazepines should be avoided due to their high potential for addiction. Okay. Anyways, benzodiazepine, before giving that, you might want to give beta blockers because that will deal with most of the symptoms that come with anxiety, like palpitations, tremors, and you know, anxiety. Takes care of all those. Okay. Key fact: abnormalities on brain imaging are common in patients with OCD. Okay. Specifically in the orbitofrontal cortex and basal ganglia, the corticostriato-thalamocortical or CSTC circuits have been implicated in the pathophysiology of the disorder. Okay, so corticostriato-thalamocortical. Okay, has been implicated in the pathophysiology of the disorder. Key fact: many patients with OCD initially present to a non-psychiatric psychiatrist. For example, they may consult a dermatologist with a skin complaint secondary to overwashing their hands. Okay, so obsessive compulsive disorder, characterized by obsession and or compulsion that leads to significant distress and dysfunction in social or personal areas. Compulsions are typically time consuming, often requiring more than 1 hour daily, like making this video for you guys. OCD typically presents in late adolescence or early adulthood. Prevalence is equal in male and female patients. It is often chronic and difficult to treat. Okay. History and physical examination, obsession, persistent, unwanted, and intrusive ideas, thoughts, impulses, or images that lead to marked anxiety or distress. For example, fear of contamination, fear of harming oneself or loved ones, compulsions or rituals, repeated mental acts or behaviors that neutralize anxiety from obsession. For example, hand washing, elaborate rituals for ordinary tasks, counting, excessive checking. Patients recognize their behaviors as excessive and irrational versus obsessive compulsive personality disorder. Okay. Um, Patients wish they could get rid of obsessions and or compulsions. Okay. So treatment here is best initial treatment: SSRIs, high dose, alternative, clomipramine, TCA, CBT, uh, using exposure and desensitization relaxation techniques, and patient education is imperative. Obsessive compulsive related disorders, so OC, obsessive compulsive related disorders, are characterized by unwanted, intrusive, recurrent, and persistent thoughts, urges, or images, as well as repetitive behavior or mental acts in response to those preoccupations. Okay. Some obsessive compulsive related disorders are primarily body focused, for example, hair pulling, skin picking, with repeated attempts to decrease or stop the behavior. Others involve mental acts that an individual feels driven to perform in response to an obsession or according to rigid set of self-defined rules. Okay, all OCD related disorders can be treated with CBT and SSRIs. Again, CBT and SSRIs. Okay. So let's check this out. A 22-year-old man presents to a physician's office. He frequently washes his hands, refuses to sit on chairs in public places, and will not use public transportation for fear of contracting diseases. He does not think his behavior are abnormal, nor does he think his behaviors interfere with his daily activities. What is the diagnosis? Okay, so here we have the difference between the two. So let's go over that. Characterized by obsession, so obsessive compulsive disorder, it's OCD. So characterized by obsession and or compulsions. Patient recognize the obsession, compulsions, and want to be rid of them. Ego dystonic. Okay. Uh, Obsessive compulsive personality disorder. This is patients are excessively conscientious and inflexible. Patients do not recognize their behavior as problematic. Okay, so the way I remember the difference between the two is the personality disorder. It's the one where they're being jerks to other people. So like if you go to shake their hands, they won't shake it. Okay, whereas obsessive compulsive disorders are like they're not being jerks to everyone. They're just being jerks to themselves. Like um, washing their hands. After turning off the lights, they gotta turn it off like 3 times. So they turn it on, off, on, off, on, off, and that's the only way they can leave the house. Before leaving the house, they gotta check their stove is off. Um, they avoid walking on cracks on the sidewalk, stuff like that. So they're not being jerks. But like here, if you with the personality disorder, uh, if you end up shaking their hands, then they'll take out their sanitizer and clean their hands with it, or it comes off as like them being very egocentric, or not egocentric, but like you know jerks basically. So here, he frequently washes his hands, refuses to sit in a chair, but most importantly, he does not think his behavior is uh, problematic, right? So that gives you that it's obsessive compulsive personality disorder. Whereas in OCD, they know it is a problem, it's just they can't stop. Okay. So this person suffers from obsessive compulsive personality disorder. These patients are perfectionists, are preoccupied with rules and order, and are often inflexible. Unlike patients with obsessive compulsive disorder, those with OCPD typically are not disturbed by their disease. Okay, if because they have made those rules for themselves, so they feel like it works, and they're in the right. Um, so no one else has like the right to tell them that it's wrong, basically. Okay. Obsessive compulsive related disorder and characteristics. So body dysmorphic disorder, a preoccupation with imagined or slight defects in physical appearance that are usually imperceptible to others, leading to significant distress, impairment. Okay. The Right. So remember Starlight from The Boys? She underwent some kind of procedure, and people were losing their minds over it. Um, but yeah, so maybe that, like the whole plastic surgery industry, cosmetic surgeries, I guess, not plastic, but cosmetic ones, is dealing with body dysmorphic disorder all the time, right? The physician should suspect body dysmorphic disorder in patient with an extensive history of cosmetic procedures. There you go. Therapeutic approach, acknowledge distress, avoid referring to complaints as imagined. Yeah, so if they're like, hey doc, I want my nose is too big. Don't be like, no, 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 your nose is perfectly fine. Don't be like that. That is not how you should be approaching this. Okay, so it should be a therapeutic approach. Acknowledge the distress. Avoid referring complaints as imagined. Evaluate level of insight. Encourage patients to avoid unnecessary cosmetic, surgical, or medical treatments. Okay. Um, okay. So plastic surgeons want to have a chat with you. Hoarding disorder. Difficulty discarding possessions, regardless of value. Attempts at discarding objects causes significant distress. Hoarding disorders results in accumulation of objects and can lead to an unsafe living environment. Oh my God! So there's a show, Hoarders. You can probably find some episodes on YouTube. Yeah. Once you watch that, you will know exactly what hoarding disorder is. Excoriation, skin picking disorder, recurrent skin picking resulting in skin lesions. Excoriation disorder causes clinically significant distress or impairment in social functioning. Okay. Patient may report repeated attempts to stop or decrease skin pricking. Differential diagnosis is pruritus caused by medical condition, for example, primary biliary cholangitis. Okay. Uh, then trichotillomania, hair pulling disorder. This is recurrent hair pulling leading to hair loss. Uh, Trichotillomania causes clinical significant distress or impairment in social functioning. Patients may report repeated attempts to stop or decrease the behavior. Clinically, hair follicle in different stages of growth and hair of different lengths will be found. Differential diagnosis, tinea capitis and alopecia. So the way you differentiate with alopecia is that in alopecia, uh, the base is going to be smooth, whereas in trichotillomania, it's going to have some kind of hair follicles still present there. Okay. uh, Kleptomania, persistent and recurrent impulse to steal items without motivators such as financial gain or personal need. Okay. Regularly associated with other psychiatric disorders such as OCD, anxiety, eating disorder, and alcohol or and substance abuse. Okay. Uh, Trauma and stress related disorders, so PTSD. Disorder characterized by clinically significant distress or impairment in daily functioning caused by exposure to an extreme life-threatening traumatic event. For example, war, assault, injury, rape, uh, accident, violent crime. Event can be either directly experienced or witnessed. Okay, key fact here. Top causes of PTSD in male patients are sexual assault and war. Top PTSD in female patients are childhood abuse and sexual assault. Okay. History and physical examination. Patients experience severe psychological distress when exposed to stimuli that remind them of the event, resulting in avoidance of situations where exposure to trigger is possible. High incidence of substance abuse, anxiety, and or depression. Okay. Diagnosis. Exposure to a traumatic event and the presence of one or more of the following intrusive symptoms, re experiencing the event through nightmares, flashbacks, or intrusive memories, avoidance of stimuli associated with the trauma. 3. Negative alteration in mood and cognition, numbered responsiveness, for example, detachment and hedonia, guilt, blaming of oneself. 4. Changes in arousal and reactivity, increase in arousal, for example, hypervigilance, exaggerated startle response, sleep disturbances, aggression, irritability, and poor concentration. Symptoms lead to significant distress or impairment in functioning. Symptoms must persist for 1 month or more than 1 month. Acute stress disorder, diagnosed if symptoms are present for less than 1 month. Okay. So that's the timeline for that. If it seems like PTSD, but it's only been 20 days or less than 1 month, 1 month or less. It's called acute stress disorder. You can only diagnose it as PTSD if it's more than 1 month. Okay, so clinical presentation is the same as PTSD. Symptoms last 3 days or more, but less than 1 month. Symptoms present within 1 month of experiencing the traumatic event. Treatment here is, again, same thing, CBT and SSRIs, but also you can have SNRIs in that case. Okay. acute stress disorder, trauma-focused CBT, or eye movement desensitization and reprocessing therapy. Pharmacotherapy, SSRIs or SNRIs, as a second line option. Prazosin, that's an alpha 1 blocker, is used to treat PTSD related nightmares. CBT alone, SSRIs alone, or a combination of both have been found to be similarly effective. Okay. Uh, okay, so neurocognitive disorders, mnemonic causes of dementia, dementias. Okay, D for degenerative disease, Parkinson, Huntington, dementia with Lewy bodies, DLB, endocrine, thyroid, parathyroid, pituitary, adrenal, metabolic, uh, alcohol, electrolyte, vitamin B12 deficiency, uh, glucose, hepatic, renal, Wilson disease, exogenous, heavy metal, carbon monoxide drugs. Okay, neoplasia, trauma, subdural hematoma, infection, meningitis, encephalitis, endocarditis, syphilis, HIV, prion disease, Lyme disease, affective disorder, pseudodementia, stroke and structure, vascular dementia, ischemia, vasculitis, normal pressure, hydrocephalus. Okay. Um, okay. So dementia, major neurocognitive disorder. A decline in cognitive functioning with global deficits. Level of consciousness is stable versus delirium. Okay. Prevalence is highest amongst those of 85 years of age or more than 85 years of age. The course is persistent and progressive. The most common cause of Alzheimer's disease, 65%, and vascular dementia, 20%. Other causes are outlined in the mnemonic dementias. Okay. History and physical examination. Patients with dementia are usually not concerned about their cognitive decline and are often accompanied to the doctor's visit by a family member or friend, versus, okay, so not concerned about their cognitive decline and are often accompanied to the doctor visit by a family member or friend. Okay, versus major depressive disorder and pseudodementia. Dementia is characterized by progressive memory impairment that can be classified into the following four stages: preclinical, slight forgetfulness, fully oriented, and capable of caring for oneself. Mild, moderate memory loss, impaired executive function, impaired function at home, but capable of maintaining most chores. Personal hygiene may need prompting. Mild, moderate, severe memory loss, inability to recognize friends, that's agnosia, impaired social judgment, requires assistance with dressing and personal hygiene. Severe memory loss, oriented only to person, completely dependent on others for ADLs, may develop aphasia and become incommunicable. Personality, mood, and behavior changes are common, for example, wandering and aggression. Diagnosis is clinical. History, physical examination, mental state examination is less than 24, or Montreal Cognitive Assessment, MOCA, is less than 26. The physician should rule out treatable causes of dementia, obtain a urine analysis, um, complete blood count, count, ESR, vitamin B12, folate, comprehensive CMP, uh, TFTs, HIV, RPR, and a head CT MRI. So basically, full blown evaluation. Definitive diagnosis requires autopsy and histopathologic exam, rarely performed. Okay. Okay. Table. outlines key characteristic distinguishing dementia from delirium. Okay, so characteristics of delirium and dementia: level of attention in delirium. So let's go through delirium. Actually, let's go through dementia first because we just did that, and then we'll continue with that. So dementia: level of attention is usually alert. Onset is gradual. Course is progressive deterioration. Consciousness is intact. Hallucination occurs in approximately 30% of patients in highly advanced state disease. ECG changes are not there. Prognosis is largely irreversible, but up to 15% of cases are a result of treatable causes and are reversible. And treatment is uh, cholinesterase inhibitor, low dose antipsychotics, primarily for behavioral disturbances and environmental changes. On to delirium. Level of attention is impaired, fluctuating. Onset is acute. Course is fluctuating from hour to hour, sundowning. Okay. Uh, Consciousness is clouded. Hallucination present, often visual or tactile. EEG changes. Sorry. Diffuse background slowing. Prognosis is reversible. Treatment is treat underlying causes, environmental changes, for example, decreased stimuli, providing frequent orientation to daytime, keeping shades up during daytime to reestablish circadian rhythm, uh, low dose antipsychotics for disruptive behaviors, agitations, and combativeness. Okay. Treatment for dementia. Pharmacotherapy. Best initial treatment is cholinesterase inhibitor, donzapil, or rivastigmine, or galantamine. Okay. Um, Moderate severe Alzheimer dementia, addition of memantine and methyl D aspartate or NMDA antagonist, aggression psychosis, low dose antipsychotics, used with caution in older adults, black box warning for increased mortality, occurrence of benzodiazepine, which may exacerbate disinhibition and confusion, provide environmental cues and a rigid structure for the patient's daily life. Family, caregiver, and patient education and supportive are imperative. Okay. Key fact here is confusion assessment method or CAM, evidence-based tool used by medical personnel to help diagnose delirium. Diagnosis can be made if both 1 and 2 are present, plus either 3 or 4. So acute onset of fluctuating course, inattention, disorganized thinking, altered level of consciousness. Question on the CAM are designed to confirm whether these features are present or absent. So for delirium, make sure that you spot out you know these. So diagnosis can be made if both 1 and 2 are present, plus 3 or 4. So you need 1 and 2, and then 3 and 4. Either of those two. Okay, so you need 3 symptoms. 1, acute onset or fluctuating course, inattention, disorganized thinking, or altered level of consciousness. Okay. So delirium, an acute disturbance of consciousness with altered cognition that develops over a short period, usually hours to days. Children, older adults, and hospitalized patients, for example, ICUs. So that's where it normally happens. Psychosis are particularly susceptible. Symptoms are potentially reversible if the underlying causes can be treated. History and physical examination. Delirium presents with acute onset of waxing and waning consciousness with lucid intervals and perceptual disturbances. Hallucination, illusion, and delusion. Okay. Patients may be combative, anxious, paranoid, or stuporous. Patients have decreased attention span and short term memory, a reversed sleep wake cycle, and increased symptoms at night and sundowning. Procure history and conduct physical and neurologic examinations. Check vital signs, pulse oximetry, electrolytes, glucose, CBC, and UA. Urine analysis. Diagnosis. Best initial treatment. Investigate common cause of delirium. A urinary tract infection, UTI, is common cause of delirium in older adults. Not note recent medications addition changes. For example, narcotics, anticholinergics, steroids, benzodiazepines. Evaluate for substance abuse and medical problems, for example, renal failure and liver failure. Treatment here is a combination of pharmacologic and non-pharmacologic intervention is often necessary. Mnemonic, major causes of delirium, eye wash death, infection, withdrawal, acute metabolic or substance abuse, trauma, CNS pathology, hypoxia, deficiency, endocrine, acute vascular MI, toxin drugs, or heavy metals. Don't worry about memorizing these, it's just basically everything. uh, just know what delirium looks like, and that's these four things right here. Okay. But yeah, if you can memorize these, uh, all the power to you. Management of delirium symptoms. Okay. Non-pharmacologic are environment, noise reduction, intervention grouping, sleep facilitation, bright day, dim night lighting, personal interaction and reassurance, physical touch, constant observation, family, professional sitters, or mobilization, out of bed, restraint, avoidance. Okay. So this is how we manage non-pharmacologically. Okay. Also, like if they're in the hospital, then having their bed in front of the nurse's department, or so overnight they can have keep a watch on them. I believe that was also part of this. Pharmacologic, pain management, non-opioid when possible, antipsychotics off-label indication, benzodiazepine, antipsychotics withdrawal symptoms. Okay. Treat underlying cause. Delirium is often reversible. Normalize fluid and electrolytes. Optimize the sensory environment and provide necessary visual and hearing aids. Use low dose antipsychotics, for example, haloperidol, for agitation and psychotic symptoms. Conservative use of physical restraints may be necessary to prevent harm to the patient or others. Okay. But we want to avoid that if we can. Okay. Key fact is it is common for delirium to be superimposed on dementia. Okay. SICAV. Okay. So mood disorders, also known as affective disorder, MDD. So mnemonic symptoms of depressive episodes is SIG ECAPS. Okay. That is sleep, hyperinsomnia or insomnia. I for interest, loss of interest or pleasure in activity. G for guilt, feelings of worthlessness or inappropriate guilt. Energy is decreased or fatigue. C for, so in caps, C for SIGI cap. Okay, so concentration and decrease. How ironic, I lost concentration while reading about concentration. Appetite is increase or decrease, or weight loss, increase, weight loss or weight gain. Okay. Psychomotor agitation or retardation, and suicidal ideation. Key fact here is major depressive episodes can be present in major depressive disorder or in bipolar disorder type 1 and 2. Key fact, another minor with suicidal ideation should be hospitalized involuntarily with or without parental consent, although parental consent is preferred. Major depressive disorder, a mood disorder characterized by one or more major depressive episodes, MDEs. The male to female ratio is 1 to 2. Lifetime prevalence ranges from 15% to 25%. Onset is usually in the mid 20s. In older adults, prevalence increases with age. chronic illness and stress increase stress risk. Sorry, chronic illness and stress increases risk. Approximately 2% to 9% of the patients die by suicide. This table outlines differential diagnosis of conditions that can be mistaken for depression. Subtype include the following: psychotic features, generally mood congruent delusions and hallucinations. Psychosis only occurs during the MDD episodes, distinguished from schizoaffective disorder. Okay, remember schizophrenia affected by MDD. So that's schizoaffective disorder, and it doesn't just mean depression, it could be manic episodes as well. And there has to be a 2 week window without any of those symptoms for it to be schizoaffective disorder. Okay. Postpartum occurs within 1 to 3 months. Postpartum has a 10% incidence and a high risk for recurrence. Psychotic symptoms are common, atypical, characterized by weight gain, hyperinsomnia, and rejection sensitivity. Okay. Um, Differential diagnosis. Okay. Okay, there's one more. Seasonal. Depressive episodes occurring during a specific season, most commonly winter. This subtype responds well to light therapy with or without antidepressants. Okay. Light therapy is pretty cool. You can YouTube it if you don't know what that is. Okay, so let's look at differential diagnosis of MDD. So, mood disorder caused by medical condition, hypothyroidism, Parkinson disease, CNS neoplasm, other neoplasms, for example, pancreatic cancer, stroke, especially anterior cerebral artery stroke, dementias, parathyroid disorders. Substance induced mood disorders, illicit drugs, alcohol, antihypertensive, corticosteroids, oral contraceptive pills, OCPs. Okay. Adjustment disorders with depressed mood, a constellation of symptoms that resemble a MDE but does not meet the criteria for MDE, occurs within 3 months of an identifiable stressor. Normal bereavement, okay, occurs after the loss of a loved one, involves no severe impairment or susceptibility. Waves of grief at reminders of loved ones usually last less than 6 months, should resolve within 1 year, may lead to MDD that requires treatment. Hallucinations of the deceased can be normal as long as the person recognizes them as such. Dysthymia, this is milder, chronic depression with depressed mood. 2 or more depressive symptoms present most of the time for 2 or more years, um, often resistant to treatment. So again, disorder, mood disorder caused by medical condition, then substance-induced medical mood disorder, adjustment disorder with depressed mood, uh, occurs within 3 months of an identifiable stressor. Okay, I believe there is a timeline for that as well. And normal bereavement, that's less than 6 months and resolves in 1 year. And dysthymia is for anything that lasts, any type of depression that lasts more than 2 years. Okay. Differential diagnosis of postpartum disorder. I believe there is a little chart. So this thing, yeah. So that will help with all these timeline things. Okay. Differential diagnosis of postpartum disorder. Subtype, time of onset, and symptoms. Postpartum blues. Time of onset, within 2 weeks of delivery, sadness, moodiness, emotional liability, no thoughts about hurting self or baby. Then comes postpartum depression. This is 1 to 3 months post delivery. Same as earlier, plus sleep disturbances and anxiety. May have thoughts about hurting self and or baby. So this is postpartum depression. Postpartum blues within 2 weeks of delivery, sadness, moodiness, emotional liability, but no thoughts about hurting. Whereas in postpartum depression, 1 to 3 months post delivery, is same as earlier, but in addition, sleep disturbances, anxiety, and may have thoughts about hurting self or the baby. Then comes postpartum psychosis, 2 to 3 weeks post delivery. Okay, so 2 to 3 weeks post delivery. Okay, this is delusions, disorganized behavior, may have thoughts about hurting baby. Okay, so we have to differentiate between postpartum depression and postpartum psychosis. Okay, blues is pretty easy to pick out, I guess, but psychosis involves delusions, so that's the differentiating point there. Okay, so yeah, TCA toxicity, mnemonic, convulsion, coma, and cardiac arrhythmias. Okay, okay, so we're on major depressive disorder. Okay, diagnosis requires depressed mood or anhedonia. This is loss of interest or pleasure, and 5 or more signs or symptoms from the SIG-ECAP mnemonic for more than 2 weeks. 2 weeks or more. Okay. Okay. It was sleep, interest, guilt, energy, concentration, appetite, weight, psychomotor agitation or retardation, and suicidal ideation. Okay. So usually these, when they're testing you on this, the question stem it's long, so that's a clue in itself. Okay. Treatment, pharmacotherapy. Best initial treatment is SSRI. Okay. Uh, so here SSRI. For example, fluoxetine, drug of choice, or sertraline, paroxetine, citalopram, escitalopram. A partial response to SSRIs can be augmented with bupropion or aripiprazole. Allow 2 to 6 weeks for medication to take effect. Dose can be adjusted as needed. The patient should continue taking the medication for at least 6 months at the same effective dose beyond the time of achieving full remission. If a patient fails to respond to the initial antidepressant, they can be switched to another first line agent, SSRI. Agents are alternatively used based on patient comorbidities, and second line treatment include those listed in this table. Okay. Most effective treatment, psychotherapy plus antidepressants, are more effective than either treatment alone. ECT, a small electrical current is used to induce a generalized seizure under anesthesia. It is a safe and highly effective treatment option for severe depression. ECT usually requires 2 to 3 treatments per week for a total of 6 to 12 treatments. Indications are as follows: refractory or treatment resistant depression, MDD with psychotic features, need for rapid improvement, actively suicidal, refusal to eat or drink, and catatonia, pregnancy, bipolar depression, or mania. No absolute contraindications. Relative contraindications include recent myocardial infarction and stroke. Intracranial mass and high anesthetic risk. Okay, so remember all of that for ECT. Okay, so refractory, again, I'll go over that. So ECT usually requires 2 to 3 treatment per week for a total of 6 to 12. Indications are as follows. Okay, you can use it for refractory or treatment resistant depression, MDD with psychotic features, need for rapid improvement, actively suicidal or refusal to eat or drink, or catatonia or pregnancy. So you can use it in pregnancy. Okay. Uh, Bipolar depression or mania, no absolute contraindication. Relative contraindications include, these are the contraindications: recent myocardial infarction, stroke, intracranial mass, and high anesthetic risk. Okay. Adverse effects: anterograde amnesia, um, post-ictal confusion and arrhythmias, and headache. phototherapy. This is effective for depression with seasonal pattern. Okay, and that's it for that. Key fact. It is important to rule out bipolar disorder before treating major depressive disorder because SSRIs can cause mania in those with bipolar disorder. Key fact. Those with 2 or more episodes should be prescribed maintenance antidepressant therapy for 1 to 3 years. Those with 3 or more episodes should have indefinite therapy prescribed. Key fact. Discontinue SSRIs at least 2 weeks before starting a MAO inhibitor. Wait 5 weeks if the patient was on fluoxetine due to its long half-life. Okay, another question. A 23-year-old woman complains of difficulty falling asleep and worsening anxiety that began 2 months earlier after she was involved in a minor biking accident. Bike versus car, in which she did not suffer any injuries. Since the accident, she has refused to participate in outdoor activities. What is her most likely diagnosis? This is PTSD, I think. Oh, it's adjustment disorder. Okay, so adjustment disorder, which consists of emotional and behavioral symptoms that develop in response to an identifiable stressors, lasts more than 1 month and less than 6 months, and does not have 5 or more symptoms of major depressive disorder. Okay, I'm gonna have to read that again. What was adjustment? Adjustment disorder with depressed mood. That's a constellation of symptoms that resemble a MDE, but does not meet the criteria for MDE. Okay, occurs within 3 months of an identifiable stress. So MDE is major depressive episode, a constellation of symptoms that resemble a major depressive episode but does not meet the criteria for major depressive episode. Okay, occurs within 3 months of identifiable stressor. Okay, so SIGCAP, sleep, interest, guilt, energy, concentration, appetite, psychomotor agitation, and suicidal ideation. Okay, so this was 23-year-old woman complains of difficulty falling asleep. Okay, so that's one, and worsening anxiety. Okay, that began 2 months earlier after. Is anxiety part of the SIGCAP? Not really, right? Okay, so two. 2 months earlier, after she was involved in a minor biking accident, in which she did not suffer any injury. Since the accident, she has refused to participate in any outdoor activities. What is her most likely diagnosis? Okay, so adjustment disorder with depressed mood. Okay. Oh, okay. Got it. Okay. Indication and side effects of common antidepressants, drug class examples, and this we already did that. We did this. Uh, we did not do this. Never mind. Sorry. So yeah, common antidepressants, drug class, example, indication, and adverse effects. SSRIs: fluoxetine, sertraline, paroxetine, citalopram, escitalopram, and fluvoxamine. Indications are depression and anxiety. Adverse effects: sexual side effects, GI distress, agitation, insomnia, tremor, diarrhea, serotonin syndrome, fever, myoclonus, hyperreflexia, altered mental status, cardiovascular collapse. Can occur if SSRIs are used with MAO inhibitors, illicit drugs, or herbal medications. Um, Paroxetine should be avoided during pregnancy. It can cause cardiac defect, first trimester, and pulmonary hypertension in third trimester in the fetus, discontinuation syndrome, flu-like symptoms, nausea, insomnia, sensory disturbances occur when abrupt cessation of shorter-acting agents. Atypical antidepressants, these are bupropion, mirtazapine, and trazodone. For depression, anxiety, smoking cessation, that's bupropion. Bupropion decreases seizure threshold, minimal sexual side effects. Okay, that's important. And contraindicated in patients with eating disorder and seizure disorders. Mirtazapine, that's weight loss, weight gain, sedation, minimal sexual side effects, and trazodone, highly sedating, and prepism is adverse effect of that. Okay. NRI, venlafaxine, duloxetine, depression, anxiety, neuropathic pain, noradrenergic side effects at higher dose. Venlafaxine is can cause diastolic hypertension. Okay, that is SNRIs. TCAs, nortriptyline, decipramine, amitriptyline, imipramine, clomipramine. Okay. Decipra, brown Monday. Depression, anxiety, neuropathic pain, migraine, headaches, enuresis, imipramine, OCD, clomipramine, antihistaminic effects, sedation, weight gain, anticholinergic effects, dry mouth, tachycardia, urinary retention, antiadrenergic effects, orthostatic hypotension, TCA overdose can be lethal and cause convulsions, seizures, coma, cardiotoxicity, prolonged conduction through AV node, prolonged QRS, hyperpyrexia, and respiratory depression. Treatment for TCA overdose, sodium bicarbonate if prolonged QRS, hypertensive or ventricular arrhythmia. Sodium bicarbonate alleviates depressant effect of TCA and cardiac fast sodium channels. MAO inhibitor, phenylazine, trenylcyclopramine, silicline, also available in patch form. Depression, especially atypical hypertensive crisis, if taken with food high in tyramine, for example, a cheese red wine. Sexual side effects, orthostatic hypertension, weight gain. We already did this one from the hypertensive crisis part from that snippet I took from step 1 FA. Right? Okay. Persistent depressive disorder or dysthymia. That's the 2-year one. History and physical examination. Persistent depressive disorder refers to the chronic depressed mood, including at least 2 depressive symptoms. 1 in children, present on most days for more than 2 years with no symptom-free periods lasting more than 2 months. Okay. Patients often have felt depressed for as long as they can remember. Double depression, diagnosed if patient meets criteria for MDD during dysthymic period. Treatment. Okay, so if you get sick cap even after 2 years, then it's double depression. Okay, so treatment. Psychotherapy is the most effective treatment. Persistent depressive disorder is often resistant to treatment. Treatments to consider are antidepressants, for example, SSRIs and ECT. Okay, so adjustment disorder. This is different from the adjustment disorder with depressed mood. Okay. So adjustment disorder, clinically significant distress following a profound life change, for example, divorce, unemployment, financial issue, romantic breakup. It is not severe enough to meet criteria for another mental disorder. History and physical examination. Patients develop anxiety or depressive symptoms, for example, anhedonia, depressed mood, and weight loss. following a stressful life event. For example, divorce, death of family member, change in school or work. Okay, so it is the same thing. My bad. Event is not life-threatening. Symptoms present within 3 months after onset of the stressor. Okay. So the accident one was within 2 months, right? Um, Adjustment disorder revolves within 6 months after event is over. Okay. Resolves, sorry. Within 6 months after event is over. Adjustment disorder causes social or occupational dysfunction as opposed to normal stress reaction. Okay, I think I remember a case from the previous QBank. It was a child who had this because his parents went through a divorce, and that was the case. Okay, treatment. Best initial treatment, psychotherapy focusing on coping skills and supportive counseling. No pharmacologic treatment required. Yeah. Key fact: premenstrual uh, dysphoric disorder or PMDD presents the same as dysthymia, but the symptoms in PMDD are cyclic, whereas dysthymia is present all the time. Okay. Okay. So bipolar and related disorder. This is dig fasts. This dig fast. Okay. Uh, Psychiatric illness characterized by episodes of mania or hypomania, with or without MDE. That's major depressive episode. A family history significantly increases risk. Okay, and increases the risk. The average age of onset is 20 years, and the frequency of mood episodes tends to increase with age. Up to 10% to 15% of those affected complete suicide. Bipolar and related disorders are classified into the following subtypes: bipolar 1, bipolar 2, and cyclothymic disorder. History and physical examination. The mnemonic dig fast outlines the clinical presentation of mania. Okay, let's go over the dig fast. It's fun to say, dig fast. Try it. Dig fast. Dig fast. Distractibility, insomnia, decrease need for sleep, grandiosity, increase self-esteem, goal-directed, flight of ideas or racing thoughts, activities, psychomotor agitation, sexual indiscretions, other pleasurable activities, talkativeness, and pressured speech. Okay, so distractibility, insomnia, grandiosity, flight of ideas, activities, psychomotor agitation, sexual indiscretions, other pleasurable activities, and talkativeness and pressured speech. Okay. History and physical examination. The mnemonic dig fast outlines the clinical presentation of mania. See this table to differentiate mania from hypomania. May report excessive engagement in pleasurable activity, for example, excessive spending or sexual activity, reckless behavior, and or psychotic features. Patients may or may not have history of a major depressive episode. See SIGI cap for mnemonic. Okay. Mania versus hypomania. Mania, more severe symptoms. Okay. Symptoms present for 1 week or more, or if hospitalization is necessary. Significant impairment in social occupational functioning, may develop psychotic features. Hypomania, less severe symptoms. Symptoms present for 4 days or more. Okay. No hospitalization is required. No significant impairment in social occupational functioning, and no psychotic features. Okay. So the way I remember it is that in hypomania, they're still functional. They have work, they have a job, and they can, you know, do it as they're meant to. Also, that if it occurs less than 1 week. In mania, it occurs 1 week or more, and they don't have work usually, or they can't work, or can't hold a job for too long. Okay, that's I remember those two. Okay. History and physical examination again. Antidepressants may trigger manic episodes without a mood stabilizer. Roperidol and other dopamine agonists can also cause mania-like symptoms. Diagnosis figure this outlines different psychiatric disorders and the duration of symptoms as part of their respective diagnostic criteria in DSM-5. Okay, so this one. Okay. Symptoms must not be caused by substance abuse or medical condition. Bipolar 1, manic episode, okay, and major depressive episode not required for diagnosis. Okay, so just need manic episode, and yeah, um, it's the one that's debilitating, right? In bipolar 2, it's the hypomanic episode. It's functional. They're functional. It's just one or more major depressive episodes are there. Okay. Cyclothymic disorder, alternating periods of the following symptoms for at least 2 years, hypomanic symptoms that do not meet criteria for hypomania, and depressive symptoms that do not meet criteria for MDE. Okay. Treatment, bipolar 1 and bipolar 2, maintenance therapy, mood stabilizers. See the table. Most patients require lifelong mood stabilizer treatment. Best initial treatment is lithium. Okay. Mood stabilizer lithium, indications and adverse effect. First line mood stabilizer used for acute mania in combination with antipsychotics, for prophylaxis in bipolar disorder, and for augmentation in depression. Treatment also decreases suicide risk. Adverse effect, narrow therapeutic window, 0.8 to 1.2 milliequal per liter. Thirst, polyuria, diabetes insipidus, tremor, weight gain, hypothyroidism, nausea, diarrhea, seizures, teratogenicity. If used in the first trimester, 0.1% risk for Epstein anomaly, acne, vomiting, hyperparathyroidism with hypercalcemia. Lithium toxicity, blood level more than 1.5 milliequal per liter, presents with ataxia, dysarthria, delirium, and acute renal failure. Contraindicated in patients with decreased renal function, sodium depletion, dehydration, and significant cardiovascular disease. Okay. Lamotrigine, second line mood stabilizer, anticonvulsant. Um, Adverse effect, blurred vision, GI distress, Steven Johnson syndrome, dosed slowly to monitor for rashes. Carbamazepine, alternative mood stabilizer, anticonvulsant, trigeminal neuralgia. Adverse effect, nausea, skin rash, leukopenia, AV block, teratogenicity, 0.5% to 1% neural tube defect, and hyponatremia due to increased ADH release. Rarely, aplastic anemia, monitor CBC biweekly, Stevens-Johnson syndrome. Valproic acid, this is bipolar disorder indication, anticonvulsants. Okay, adverse effect, GI side effect, nausea, vomiting, tremor, sedation, alopecia, weight gain, teratogenicity, 3% to 5% risk for neural tube defect, um, rarely pancreatitis, thrombocytopenia, fatal hepatotoxicity, and agranulocytosis. That's an important one as well. Contraindicated in patients with hepatic disease. Okay, so again, GI side effects, nausea, vomiting, tremor, sedation, alopecia, weight gain, teratogenicity, 3% to 5% risk for neurotube defect, rarely pancreatitis, thrombocytopenia, fatal hepatotoxicity, and agranulocytosis. Contraindicated in patients with hepatic disease. Okay, now sleep disorder. Okay, so hold on. Let's take a break here. So, uh, this chart, sleep disorder, narcolepsy, more than 3 months. Okay, so 3 months and onwards. That childhood disorders, selective mutism is going to be 1 month and above. Same as separation anxiety. ADHD, specific learning defect, and occupational defiant, again 6 months and more. And for tic disorder and disruptive mood dysregulation, it has to be 1 year or more. Okay. Anxiety disorder, if it's less than 1 month, acute stress more than 1 month, it's panic or post-traumatic stress. Uh, for adjustment, it has to be less than 6 months, and generalized anxiety is 6 months or more. Okay, and phobias, same thing, 6 months or more. Okay. Psychotic disorder, that is brief psychotic, is going to be less than 1 month. Uh, between 1 month and 6 months, it's schizophreniform, and delusion is going to be more than 1 month and above, and schizophrenia is 6 months and above. Mood disorder, manic symptoms of bipolar, more than 1 week. Okay, and major depressive is going to be more than 2 weeks. Okay, and dysthymic and cyclothymic are 2 years or more. Okay. Okay, so we were at bipolar. Cyclothymic was alternating periods of the following symptoms for at least 2 years. Okay. So we're still doing bipolar. Okay, so for bipolar treatment, acute mania, consider a psychiatric emergency because of impaired judgment and risk of for harm to self or others. Mild to moderate mania, atypical antipsychotics, olanzapine, quetiapine. Severe mania, mood stabilizer, lithium valproate uh, plus antipsychotics. Refractory mania, ECT, mania, hypomania, and pregnancy, antipsychotics. Typical antipsychotics, for example, haloperidol, are generally first line and have fewer risks to the developing fetus than mood stabilizers. ECT can be used for severe or refractory mania in pregnancy. Bipolar depression, mood stabilizers with or without antidepressants. The patient should begin the mood stabilizer first to avoid inducing mania. The physician may also try a combination of mood stabilizer and antipsychotic if monotherapy fails. Okay. Mood stabilizer. Okay. Personality disorder. Personality can be defined as an individual set of emotion and behavioral traits which are generally stable and predictable. Personality disorder are defined when one's trait become chronically rigid and maladaptive, leading to social or occupational dysfunction. Disorders are outlined in this table. Signs and personality disorder. So, disorder characteristic and clinical presentation. Weird. Cluster A is weird, wild, and worried and wimpy. Okay, that's cluster C. So paranoid, it's distrustful, suspicious, interprets others' motive as malevolent, and note these patients commonly use projection as a defense mechanism. Clinical presentation. A 59-year-old man who lives alone constantly feels that his neighbor's children are spying on him and plotting to break into his home. He has installed security cameras all around his property to obtain proof. He feels he cannot trust the police to do a good job because they will probably take the side of his neighbors. Schizoid, isolated, detached loners who prefer to be alone, restricted emotional expression. Clinical presentation. A 66-year-old man who moves to Thailand alone after retirement has no desire to remain in contact with his family and is very distant in his interactions. He stays in his remote accommodations without unnecessary travel and does not crave interaction with the locals. Schizotypal. Okay, that's the crystal ball one. Uh, Odd behavior, perception, and appearance, magical thinking, ideas of reference. A 35-year-old man with strange ideas regarding the importance of crystals, and they their effects on health. He meticulously mines and collects crystals, feeling that they will one day prevent him from acquiring cancer. Okay, so cluster A is paranoid, schizoid, and schizotypal. Wild, borderline, that's unstable mood, relationships, and self image, feeling of emptiness, impulsive, history of suicidal ideations or self harm. Note these patients often employ splitting as a defense mechanism. A 28-year-old woman presents to the clinic after having praised her new clinician as better than all the others. Okay, that is splitting. Okay, she reveals that, well, that's not splitting, that's just praising. Okay. She reveals that she fired her last therapist as he was not really helping. The physician notices she has fresh cuts in a row on her forearm. Okay, so splitting is part of borderline. Okay, so that. Oh, it says note these patients often employ splitting as a defense mechanism. Okay. Histrionic, excessively emotional and attention seeking, sexual provocation, theoretical, theatrical, theatric. Oh wow, it's time for me to sleep. Theatrical. I'm just gonna skip that. A 35-year-old woman presents to clinic wearing a very low cut blouse and adjusting her position to draw attention to herself. When she does not get attention, she breaks into tears, saying that no one notices her, uh, not even her friends. So sort of like hysteria, right? Narcissistic, grandiose, needs admiration, has sense of entitlement, lack of empathy. A 45-year-old man impatiently taps his foot in the waiting room of the office. He approaches the reception and demands to know where the doctor is and tells her that he will have her fired, and the doctor reported if he is not seen shortly as he believes his time is being wasted in a queue. Antisocial, violates rights of others, social norm, and laws. A 28-year-old man who has committed a brutal assault ends at a court-ordered psychiatric appointment. When a teenager, he was in he was in juvenile detention for theft. He says he does not need to be seen by a shrink, and that's because he was offended by the victim. They deserve to be assaulted. Okay. So, evidence of conduct disorder before 15 years of age. Okay. We talked about conduct, so this is just that them getting in trouble with the law. Okay. Uh, and worried and wimpy, obsessive compulsive is type C, cluster C, preoccupied with perfection, order, and control at the expense of efficiency, inflexible morals and values. Note, remember, in contrast to obsessive compulsive disorder, patients with obsessive compulsive personality disorder do not feel their behavior is problematic, egocentric. They also do not have true obsession and compulsions. A 35-year-old woman presents to the office at the request of her boss, who feels she is too focused on minute details on team projects and does not allow others to participate for fear of unwanted errors. She does not see anything wrong with the style of work, as she believes her coworkers cannot be trusted to pay adequate attention to details. Okay. Avoidant, socially inhibited, sensitive to rejection, fear of being disliked or ridiculed, yet desire to have friends and social interactions. Clinical presentation. A 33-year-old man stays at home to avoid office party as he fears having to make small talk. He wants to go, but he's more afraid that he will be inadequate or rejected by others. Okay. So you gotta contrast this with the schizoid type. Dependent, submissive, clingy, feels a need to be taken care of, has difficulty making decisions, feels helpless. clinical presentation. A 30-year-old woman presents to the physician's office in crisis, saying that her parents just kicked her out of their house and that she is struggling to survive on her own. She says she cannot make her own choices at the grocery stores as her mother would always care for her. And now these decisions are overwhelming. She has been sitting outside of their house daily, hoping they will let her live there again, independent. So this is kind of where you will have to contrast it with the borderline, because that also causes dependency issues, right? Unstable mood relationship and emptiness, impulsive. Okay. Um, okay. But anyways, so what were we reading? So personality disorders. Defense mechanisms are methods of dealing with anxiety or conflicts of the ego. For example, anger, guilt, inadequacy, grief. These can be immature, more primitive, or mature, more sophisticated. Immature defense mechanisms are common in personality disorder. Important defense mechanisms are outlined in this table. Okay, so defense mechanisms, immature ones and mature ones. Immature ones are expressing unacceptable feelings and thoughts through actions. Denial, acting as if an aspect of reality does not exist. Refusing to accept the situation. Displacement, transferring feelings or impulses to more neutral object. Intellectualization, using facts and logic to avoid stressful thoughts or emotions. Passive aggression, that's demonstrating hostile feelings in a non-confrontational manner. Projection, attributing an unacceptable internal impulsive to others, versus displacement, associated with paranoid uh, personality disorder. So this is attributing an unacceptable internal impulse to other. Okay, whereas displacement was transferring feelings or impulses to more neutral object. Okay, so okay, so throwing a glass at the wall, I guess that would be displacement. Projection is uh, accusing your partner that they're cheating. It's because you're more interested in cheating. Okay, so that would be the projection one. Um, Rationalization, explaining unacceptable behaviors in a rational or logical manner. Okay. Reaction formation, behaving in a manner opposite to one's true feelings and thoughts. That's the one where a stepmother um, is doesn't like the child, but in front of everyone, or to make up for that, they overly care for the child. It's called reaction formation. I'm not explaining it right, but it's the example from the step one book. Okay. uh, Regression, involuntarily reverting to an early developmental stage, associated with dependent personality disorder. Okay, so involuntary reverting to an earlier developmental stage. That's the one where a child, on arrival of a newborn, goes back to, wetting the bed, something like that. Or was this the one where the surgeon was unable to handle a criticism from a nurse or something, and I forgot. But anyways, regression. We'll figure it out during the Q&A. Splitting, believing that people are either all bad or all good, associated with borderline personality disorder. Mature, sublimation, that's channeling an unacceptable thought or wish into a socially acceptable outlet or behavior. Okay, so it's when the child channels his anger towards the parents or whatever into sports, like that. Altruism, coping with difficult stressors by meeting the needs of others, uh, like what I'm doing by making this video for you guys. Suppression, intel- intentionally avoiding unwanted thoughts or feelings to deal with reality. Okay, um, that's what you're doing by watching this video. Humor, joking about an uncomfortable or anxiety provoking situation. Uh, Basically, my examples throughout this video. Okay. Diagnosis. Diagnosis is clinical and detailed. History taking is imperative. Collateral information may be helpful. Patients typically deny or do not realize they have a problem. Egocentonic. Treatment. Best initial treatment. Psychotherapy. Pharmacotherapy is reserved for cases with comorbid mood, anxiety, or psychotic signs and symptoms. So, characteristic of personality disorder. Medic. Maladaptive, enduring, deviate from cultural norm. Inflexible, causes impairment to in social or occupational functioning. Okay, on to substance use disorder. Okay. Substance use disorder is a maladaptive pattern of substance use that leads to clinically significant impairment. It can be applied to most substances of abuse. The patient must meet two or more of the 11 criteria within a 1 year period for diagnosis. The criteria can be grouped into four categories of symptoms and are as follows: impaired control, consumption of greater amounts of the substance than intended, failed attempts to cut down use or abstain from the substance, increased amount of time spent acquiring the substance, using it, or recovering from effects, and craving, social impairment, failure to fulfill responsibility at work, school, or home, continued substance use despite recurrent social or interpersonal problems secondary to the effects of such use. For example, frequent arguments with spouse over the substance use, isolation from life activities, risky use, use of substance in physical hazardous situation, for example, driving while intoxicated, continued substance abuse, despite recurrent physical or psychological problems, secondary to the effects of the substance use, pharmacologic tolerance and use of progressively large amounts to obtain the same desired effects, and withdrawal symptoms when not taking the substance, tolerance and withdrawal are not needed to make the diagnosis. Okay, withdrawal, psychologic syndrome that occurs when concentration of a substance decline in an individual who has had prolonged heavy use of that substance. Symptoms vary greatly across substances. Okay, symptoms vary greatly across substances, but when they occur, the individual is less likely to consume the substance again in order to relieve the symptoms. For most substances, a history of withdrawal is usually associated with a more severe clinical course. Okay. Um, Key fact here: pinpoint pupils are not always a reliable sign of opioid ingestion because co-ingestions can lead to normal or enlarged pupil. Also, look for decreased respiratory rate, track marks, and decreased breath sounds. Okay, so that as well. Okay. Key fact: acute pain management is the same for all patients with severe pain refractory to NSAIDs, regardless of a history of substance abuse. In the appropriate clinical setting, a prior substance abuse is not a contraindication to the use of opioids in pain management and require a non judgmental environment and shared decision making. Okay. Uh, Diagnosis and treatment. Diagnosis is typically clinical and detailed. History taking is imperative. Lab tests, urine and blood toxicology screens, liver function tests, LFTs, and serum ethanol, ETOH. Okay. Severity is determined by a number of symptoms present: mild, 2 to 3, moderate 4 to 5, severe 6 or more. Symptoms of intoxication and withdrawal from selected drugs are described here. Okay, so this. Sign and symptoms of substance abuse: drug, intoxication, withdrawal, depressants, alcohol, disinhibition, emotional liability, slurred speech, ataxia, aggression, blackout, hallucination, memory impairment, impaired judgment, stupor, coma. Withdrawal: 6 to 24 hours, anxiety, tremor, tachycardia, hypertension. 12 to 24 hours, hallucinations. 12 to 48 hours, seizures. 48 to 96 hours, delirium tremens, fever, agitation, hypertension, and hallucination. Opioids: euphoria leading to apathy, central nervous system depression, uh, constipation, pupillary constriction. Okay, so that's number one. That gives away this. Respiratory depression. That's also classic presentation for opioid poisoning. Uh, Opioid poisoning, intoxication, life-threatening and overdose, bradycardia. Acute reversal of opioid intoxication is naloxone. Okay, short-acting, so repeat dosing needed. To prevent relapse, naltrexone. Okay, uh, this is longer acting, the one with the L in it. Okay, withdrawal, dysphoria, insomnia, anorexia, myalgias, fever, lacrimation, diaphoresis, dilated pupils, rhinorrhea, piloerection, that's goosebumps, uh, tachycardia, nausea, vomiting, stomach cramps, diarrhea, yawning. Okay, so piloerection is an important presentation for this as well. Okay, so opioid withdrawal is not life-threatening, hurts all over, and does not cause seizures. It can be treated with buprenorphine or methadone. Okay, remember these are for withdrawal in case of opioid withdrawal. Okay, synthetic opioids contains MPTP, synthetic heroin, leading to Parkinson-like disorder and loss of pigmented neurons in the substantia nigra. Okay, no withdrawals for these. Barbiturates, long safety margin, respiratory depression, anxiety, seizure, delirium, life-threatening cardiovascular collapse. Benzodiazepine interactions with alcohol, amnesia, ataxia, somnolence, mild respiratory depression. Should not be used for insomnia in older adults. Can cause paradoxical agitation in relatively low doses. Okay, so you gotta remember this is the one with the ataxia, because it the symptoms overlap with opioids, right? But opioid, you don't get ataxia, whereas in benzodiazepine you will have that. Okay, and with withdrawal you get rebound anxiety, seizure, tremor, insomnia, hypertension, tachycardia, and death. Okay, inhalants, solvents, glue, and fuel. Tachycardia, nystagmus, tremor, ataxia, slurred speech, unconsciousness, followed by drowsiness and headache, perioral rash, common among adolescents. Short duration of action. Long-term use can lead to irreversible CNS damage and polyneuropathy due to vitamin B12 deficiency, dysphoria, headache, and irritability. Stimulants, amphetamines, psychomotor agitation, impaired judgment, hypertension, pupillary dilation, tachycardia, fever, diaphoresis, anxiety, angina, euphoria. Um, Kendrick Lamar just dropped a track, Euphoria, um, about 5-6 hours ago. Grandiosity, prolonged wakefulness, attention, arrhythmias, delusions, seizures, hallucinations, skin excoriations, poor dentition, meth mouth. Haloperidol can be given for severe agitation and symptom-targeted medications, for example, antiemetic NSAIDs. Post-use crash with anxiety, lethargy, headache, stomach cramp, increased appetite, fatigue, depression, dysphoria, sleep disturbances, and nightmare. Okay. Uh, Psychomotor agitation, euphoria. I have this impulse every time I see this word, I have to like sing it in Bohemia's. The way Bohemia says, "Ko कहने कितने मैंने चढ़े आए जोश." Okay, psychomotor agitation, euphoria, impaired judgment, tachycardia, pupillary dilation, hypertension, paranoia, hallucinations, cocaine bugs, the feeling of bugs crawling under one's skin, sudden death. Chronic use causes decreased appetite, weight loss, erythema of the nasal turbinates, and septum perforation. ECG changes from ischemia are often seen. Cochlear chest pain. Treatment: benzodiazepine, non-selective alpha and beta blockers, for example, labetalol. Withdrawal: post-use crash with hypersomnolence, depression, malaise, increase in appetite, angina, suicidality, and nightmares. Okay, so post-use crash is real. Okay, guys. So don't keep a lookout for that, basically. Okay, and it may seem like most of these withdrawals, they do seem like it's how do you say, overlap a lot of these things. So you gotta first figure out if it's intoxication you're dealing with or withdrawal, and that way you can separate the two. Okay. Um, okay. Caffeine, restlessness, insomnia, diuresis, muscle twitching, arrhythmias, tachycardia, flushed face, psychomotor agitation, headache, lethargy, depression, weight gain. Okay, again, it sounds similar to this a lot. Irritability, craving. Okay, uh, nicotine, restlessness, insomnia, anxiety, arrhythmias. Okay, irritability, headache, anxiety, weight gain, craving, bradycardia, difficulty concentrating, and insomnia. Hallucinogens, PCP, the violent one. Assaultive combative, belligerence, psychosis, violence, impulsiveness, psychomotor agitation, fever, tachycardia, vertigo, horizontal nystagmus, hypertension, impaired judgment, ataxia, seizures, delirium. Benzodiazepine or haloperidol can treat severe symptoms, otherwise physicians should offer reassurance. Gastric lavage can help eliminate the drug. Recurrence of intoxication symptoms caused by reabsorption in the GI tract. Uh, Sudden onset of severe random violence. LSD, marked anxiety or depression, delusions, visual hallucinations, flashbacks, pupillary dilation, impaired judgment, diaphoresis, tachycardia, hypertension, heightened senses. For example, colors become more intense. Treatment: supportive counseling, traditional antipsychotics for psychotic symptoms, benzodiazepines for anxiety. Marijuana, tetrahydrocannabinol or THC, um, euphoria, um, laughter, slowed sense of time. Again, euphoria. The TV show, it was produced by Drake as well, and Kendrick Lamar just dropped a diss track named Euphoria. Okay, just letting you guys know. Euphoria, laughter, slowed sense of time, impaired judgment, social withdrawal, appetite, dry mouth, conjunctival injection, hallucinations, anxiety, paranoia, decreased motivation, irritability, anxiety, decreased appetite, insomnia. Bath salts, synthetic catenones. Stimulant drug that causes agitation, combativeness, delirium, and psychosis that may last for weeks, not detected on routine urine toxicology screens. Anxiety, depression, insomnia. Gamma hydroxybutyric acid, GHB. Hypotension, bradycardia, respiratory depression, disinhibition, increase in libido, and seizures. Irritability, anxiety, tremor, autonomic instability. MDMA, ecstasy. Amphetamines, derivative with hallucinogenic properties, popular at dance parties or raves. Intoxication, hypertension, euphoria, uh, perpetual changes, bruxism, hyperthermia, heat exhaustion, hyponatremia may also precipitate serotonin syndrome, depression, anxiety, difficulty concentrating. Alcohol use disorder. Okay. Alcohol use disorder occurs more often in males, 4 to 1, and in those 21 to 34 years of age, although the incidence in females is rising. Alcohol use disorder is associated with a positive family history. History and physical examination see this table for the symptoms of intoxication and withdrawal. The physician should look for palmar erythema or telangiectasia and for other signs and symptoms of an organ complications. Patients often present with sleep disturbances or anxiety symptoms caused by mild withdrawal. Diagnosis Screening can be done with Cage questionnaire. The physician should monitor vital signs for evidence of withdrawal. Labs may reveal increase in LFTs, classically aspartate aminotransferase, alanine aminotransferase ratio more than 2.2 to 1. Increase in lactate dehydrogenase or LDH, increase in carbohydrate deficient transferrin, and increase in mean corpuscular volume, right, MCV, more than 100. So Cage questionnaire, what are these? Number one, you ask, have you ever felt the need to cut down on your drinking? Two, have you ever felt annoyed by criticism of your drinking? Three, have you ever felt guilty about drinking? Four, have you ever had to take a morning eye opener? Okay. Now, more than one yes answer makes alcohol use disorder likely. Okay. So CAG, C for cut, A for annoyed, G for guilt, and E for eye opener. Okay. Uh, Treatment here: abstinent, abstinence, abstinence. Best initial treatment: naltrexone. Okay, it's a mu opioid receptor blocker. It decreases cravings. Can start while patient is still drinking. Long-term rehabilitation, for example, Alcoholics Anonymous. Aversion, so disulfiram, acetaldehyde dehydrogenase inhibitor, produces an unpleasant response. For example, flushing, nausea, vertigo, palpitations when ethanol is consumed. Okay, so it causes basically hangover symptoms. Withdrawal, stabilization of vital signs, correction of electrolyte abnormalities, thiamine, administer before glucose to prevent Wernicke encephalopathy, glucose and folic acids. Okay, that is important. So if you're giving thiamine, administer glucose to prevent Wernicke's. Okay, glucose and folic acid. uh, Medium length benzodiazepine taper, for example, lorazepam, diazepam, or chlordiazepoxide. Addition of haloperidol for hallucination and psychotic symptoms. Okay, so the first line is correction of electrolyte abnormalities. Okay, sorry. Best initial treatment. First line is naltrexone. Sorry. Okay, for abstinence. Withdrawal. First line for that was electrolyte imbalance. Okay. Uh, so, so naltrexone, mu opioid receptor blocker. Complications: gastritis, gastrointestinal GI bleeds, ulcers, varices, or Mallory wise tears. Okay. Um, Pancreatitis, liver disease, delirium tremens, alcoholic hallucinations. See this table and this figure. Peripheral neuropathy, Wernicke encephalopathy. Uh, there was a mnemonic for that, Kano, right? Korsakoff, psychosis, fetal alcohol syndrome, cardiomyopathy, anemia. Um, so that's CA. Okay. Aspiration pneumonia, increased risk for sustaining trauma, for example, subdural hematoma. Um, C was cardiomyopathy, A was anemia, N was neuropathy, and O was ophthalmopathy, ophthalmic, uh, something to do with that. That they have not put down here. Okay. Okay. Yeah, I don't see it. Okay, so here, alcoholic hallucination versus delirium tremens. So alcoholic hallucination 12 to 24 hours since last drink, visual, auditory, and tactile hallucinations. Delirium tremens 48 to 96 hours since last drink, autonomic instability, hyperadrenergic state, increase in blood pressure, increase in heart rate. Okay, so that's how you differentiate between the two. Disorientation, agitation, okay, and hallucinations. So this occurs 48 hours to 96 hours. Okay, so here we have a timeline for that. So 3 hours from drinking, tremors, insomnia, diaphoresis, agitation, GI upset. This can happen anytime between 3 hours to 36 hours. Okay, um, withdrawal seizures happen 6 hours to 48 hours. Alcoholic hallucination 12 hours to 48 hours. Anything beyond that is considered delirium tremens. Alcohol withdrawal timeline. Alcohol withdrawal can have overlapping symptoms. Time from last drink is important to delineate the type of withdrawal and subsequent management. Okay, moving on. Symptoms and treatment of drug withdrawal. So for alcohol, withdrawal is life-threatening, mortality up to 5%, mild withdrawal, tremors, first symptom, tachycardia, hypertension, agitation within 48 hours, alcohol hallucination, visual hallucination without delirium, 12 hours to 48 hours, and delirium tremens, visual hallucination with severe autonomic instability, delirium, seizures, and possible death within 2 to 7 days. Treatment here is benzodiazepine can require massive doses. Thiamine folate multivitamin replacement banana bag does not affect withdrawal. Um, People with alcoholics uh, use disorder. Okay, so this is okay. Multivitamin replacement banana bag. Okay, I think that's just something they call it. Well, call multivitamin replacements. Okay. Um, Benzodiazepines and barbiturates. Life-threatening. Mortality is rare. Uh, Tremor. Adjust my chair. Gives me in this sound. Okay. Benzodiazepine and barbiturates. Life-threatening. Mortality is rare. Tremor. Rebound anxiety, insomnia, delirium, hallucinations, seizures, may mimic alcohol withdrawal, but hypertension, tachycardia usually are absent. Okay, so this is how you differentiate between the two withdrawals, and they are overlapping, right? You see tremor, rebound anxiety, insomnia, delirium, hallucination, seizures. Okay, may mimic alcohol withdrawal, but here we see hypertension that they have not mentioned. Oh, there you go. In mild, right? So hypertension and tachycardia. It doesn't happen in benzodiazepine or barbiturate withdrawal. So treatment here is benzodiazepine taper. Cocaine and amphetamines, non-life threatening. Uh, Depression, hyperphagia, hypersomnolence, and constricted pupils. Okay, so cocaine will cause constricted pupils. Uh, it's withdrawal basically. Uh, Treatment is IV benzodiazepine and supportive treatment. Avoidance of pure beta blockers lead to unopposed alpha activity, causing hypertensive crisis. Okay. Opioids, not life-threatening. Anxiety, insomnia, flu-like symptoms, piloerection, um, fever, rhinorrhea, lacrimation, yawning, nausea, stomach cramps, diarrhea, and dilated pupils. Mild, if it's mild, then ondansetron, loperamide, benzodiazepine, NSAIDs. Severe, then clonidine for autonomic symptoms, buprenorphine, or methadone for craving. Okay. Here I just wanted to check one thing. Um, in cocaine, the withdrawal. Okay, so how do you treat it? Benzodiazepine, non-selective alpha beta blockers. Okay, so you do give beta blockers, but before you do that, you gotta give non-selective alpha blocker. Okay, that is important there. Um, Lipitor. So in case the option doesn't have benzodiazepine, then you gotta pick this. Moving on. Key fact on neonatal abstinence syndrome occurs when a neonate suffers symptoms of substance withdrawal because of in utero exposure to that substance on a consistent basis. Okay. Um, there was an episode on South Park. It wasn't because of alcohol. It was because the pregnant ladies, they were like crack addicts, and then all their babies wanted crack as well. It was a funny episode on South Park. Management of drug withdrawal table summarizes common drug withdrawal symptoms and treatment. Okay, uh, okay, then that. Eating disorder, anorexia nervosa. Risk factors include female sex, low self-esteem, and high socioeconomic status associated with OCD, MDD, anxiety, and career hobbies such as modeling, gymnastics, ballet, and running. Okay. History and physical examination. Patients are often perfectionists and high achieving. They have a distorted body image and fear of gaining weight. Anorexia nervosa is divided into two subtypes: restrictive and binge eating purging. Okay. So restrictive, severe restriction of food intake is primary method of weight loss, and binge eating or purging type is food intake is compensated by purging or excessive exercise, vomiting, laxative diuretic abuse. Signs and symptoms: cachexia. Body mass index is less than 18.5 kilograms meter squared. You'll have lanugo, um, dry skin, bradycardia, lethargy, hypertension, cold intolerance, and hypothermia. See the table to differentiate anorexia nervosa from bulimia nervosa. Okay. Diagnosis: measure height and weight, check BMI, check CBC, electrolyte, endocrine levels, and ECG. Perform a psychiatric evaluation to screen patients for comorbid conditions. Treatment in this table. Complications: see this table and this table. Mortality from suicide or medical complication is more than 10%. So anorexia versus bulimia nervosa. So anorexia, it's persistent restriction of caloric intake, resulting in low body weight, intense fear of gaining weight, distorted body image. Patients perceive these themselves as overweight or obese. Patients are underweight. Um, BMI is less than 18.5 kg per m squared. Okay. Um, Attitude towards illness. Patients are typically not distressed by their illness and may thus be resistant to treatment. Treatment: monitor calorie intake and weight gain. Hospitalize if necessary. Watch for refeeding syndrome, electrolyte abnormalities, decrease in phosphate, arrhythmias, uh, respiratory failure, and seizures after sudden increase in caloric intake. Psychotherapy: address maladaptive family dynamics. Antidepressants, SSRIs, Note that these are not effective weight until weight is restored. Treat comorbidities, avoid bupropion because of risk of seizure. Bulimia nervosa, episodes of binge eating followed by compensatory behavior like purging, fasting, excessive exercise. Okay. Um, Episodes occur at least once a week for 3 months. Patient are normal weight or are overweight. Okay, so BMI is more than 18.5. That's basically going to be the differentiating factor between anorexia, purging type, and bulimia. Okay. Attitude towards illness. Patients are typically distressed about their symptoms and are thus easier to treat. Treatment. Psychotherapy with or without antidepressants, SSRIs, treat comorbidities, avoid bupropion because of risk of seizure. Okay. So here treatment was monitor calorie intake and weight gain, hospitalize if necessary. Treatment, watch for refeeding syndrome. Okay, that's the important one that you want to look out for. Psychotherapy, SSRIs, and treat comorbidities. Medical complications of eating disorder. Constitutional, cardiac, gastrointestinal, genitourinary, and others. Okay. Constitutional, cachexia, hypothermia, fatigue, electrolyte abnormalities, hypokalemia, pH abnormalities. Cardiac, arrhythmia, sudden death, hypertension, bradycardia, prolonged QT interval. Gastrointestinal, dental erosion and decay. Abdominal pain, delayed gastric emptying. Genitourinary, amenorrhea, nephrolithiasis. Others, uh, dermatologic langue, hematologic leukopenia, neurologic seizure, and musculoskeletal osteoporosis and stress factor. Bulimia nervosa, eating disorder characterized by recurrent episodes of binge eating and compensatory purging behavior. For example, vomiting, laxative, diuretic abuse, excessive exercise. More common in females associated with low self esteem, mood disorders, and OCD. History and physical examination. Patients often have a long history of other comorbid psychiatric conditions, for example, anxiety, depression, and are concerned about their behavior. Signs: dental enamel erosion, enlarged parotid glands, scars on the dorsal hand surfaces, if there is a history of repeated induced vomiting, and BMI more than 18.5 kilogram meter squared, um, are signs of bulimia nervosa. See this table to differentiate anorexia nervosa from bulimia nervosa treatment. See this table. Complications. See this table for a summary of complications related to eating disorder. Sexual disorders, sexual changes with aging. Interest in sexual activity usually does not decrease with aging. Male usually require increased stimulation of the genitalia for longer periods of time to reach orgasm. Intensity of orgasm is decreased and the length of refractory period before the next orgasm increases with aging. In females, estrogen levels decrease from menopause, leading to vaginal dryness and thinning, which may result in discomfort during coitus. The patient may be treated with hormone replacement therapy, estrogen vaginal suppositories, or other vaginal creams. Paraphilic disorders, preoccupation with or engagement in unusual sexual fantasies, urges, or behaviors for more than 6 months with clinically significant impairment of one's life. There are 8 classified disorders characterized by disordered courtship, voyeurism, exhibitionism, and forturism. Uh, which one is that? Oh no, I'm gonna have to Google this now. Things I do for completeness sake. So, forturism is the act of touching or rubbing one's genitals up against another person in a sexual manner without their consent to derive sexual pleasure or reach orgasm. This reminds me of an episode from Friends where Joey goes on to get his um no he Joey, yeah, I think it was Joey's Taylor that like rubs himself against Joey while measuring his pant length, and then uh, Chandler goes and then he does it on it, and then he comes back and it's like, this is not normal. And Joey's like, everybody, all my family members get it done there. This is normal. Reminds me of that. Anyways, going on. No, where were we? So, for tourism, disordered preferences, pedophilia, transvestic fetishism, and fetishism. Okay, and pleasure in inflicting or receiving pain, 50 Shades of Grey, sadism, and mosaicism. That's what I've heard. I have not seen it. Okay, so for the record, I have not seen 50 Shades of Grey. Treatment includes insight-oriented psychotherapy and behavioral therapy, anti-androgen, for example, a uh, medroxyprogesterone injection, have been used for hypersexual paraphilic activity. Gender dysphoria, significant incongruence between one's gender identity and one's gender assigned at birth, lasting more than 6 months and leading to persistent distress. Okay. Individuals experience marked discomfort and assigned gender, which interferes with social, academic, and other areas of function, more common in males than females. History and physical examination, more common in males than in females. Gender dysphoria is associated with depression, anxiety, substance abuse, and personality disorders. Some individuals who are transgender will experience gender dysphoria. Nonconformity to one's assigned gender itself is not a mental disorder. Okay. Gender dysphoria is associated with depression, anxiety, substance abuse, and personality disorder. Okay. Treatment address comorbid psychiatric conditions. If the patient is interested, discuss options for gender affirming surgery or hormonal treatment. In teens, hormone suppression therapy can be offered to delay puberty, but this decision should be made with support from family if possible. One should also assess safety and multidisciplinary specialist services. Okay. Sexual dysfunction, history and physical examination, problems in sexual arousal, desire, or orgasm or pain with sexual intercourse. Prevalence 30%. One third of cases are attributable to biologic factors and another third to psychological factors. Okay, so problems in sexual arousal, desire, or orgasm or pain with sexual intercourse. Here, the treatment was comorbid psychiatric condition. If patients interested, discuss option of gender affirming surgery or hormonal treatment. So notice how there is no age limit for this. Okay. In teens, hormone suppression therapy can be offered to delay puberty. Okay. But this decision should be made with support of family if possible. One should also assess safety and multidisciplinary specialist service. So, yeah. Sexual dysfunction, again, that prevalence 30%, one third of the cases are attributable to biologic factors and another third to physiologic factors. Treatment depends on the condition. Physiologic strategies include phosphodiesterase type 5 inhibitors, sildenafil or tadalafil. If dysfunction is caused by antidepressants, SSRIs, the physician can institute a switch to bupropion, or psychotherapeutic strategies includes sensate focusing. Okay. Um, when you're dealing with this sexual dysfunction, one way to figure out if it is psychological or pharmacological is if they're getting morning wood. Okay. If they're getting uh, nocturnal erections, um, then it is psychological. It's not pharmacological. If it was pharmacological, they wouldn't get any kind of erections in any time of the day or night. Okay. Features of common paraphilic disorder and clinical manifestations. Exhibitionistic. This is sexual arousal from exposing one's genitals to a stranger. Okay. That reminds me of this episode again from The Office where Phyllis was coming into the office from the parking lot and she got flashed by some guy in a trench coat. And by the end of the episode, Pam had drawn up a sketch of the culprit, and it and Dwight was posting it all around this area, and then it turned, and then he realized that it looks like him. It was a good prank. Um, Pedophilic urges or behaviors involving sexual activities with children. Okay, um, so CPs. Voyeuristic, uh, observing unsuspecting people unclothed or involved in sex. Okay. Okay. Fetishistic. Uh, okay. Use of non-living objects, often clothing, for sexual arousal. Okay. Uh, reminds me of that famous scene from American Pie with the cake. Uh, transvestic. Uh, no, actually, that wasn't. I wouldn't. I don't think that would be considered fetishistic. Okay. Transvestic. That's cross-dressing for sexual arousal. Okay. The thing with transvestic disorder, it's not that they want to be considered the other gender, as far as I know. Um, it's just that they enjoy cross-dressing. Okay. Um, so Futuristic. This is touching or rubbing one's genitalia against a non-consenting person, common in crowded places. We looked at that. Um, Sexual sadism. Um, we looked at as in we looked up the definition. We didn't look at that. Okay, for the record. Sexual sadism. Sexual arousal from inflicting suffering on sexual partner. Okay. Um, Sexual masochism, that's sexual arousal from being hurt, humiliated, bound, or threatened. Okay. Moving on to sleep disorders. Up to one third of all American adults suffer from some type of sleep disorder during their lives. Dysomnia describes any condition that leads to disturbance in the normal rhythm or pattern of sleep. So that's probably us. Insomnia is the most common example. Risk factors include female sex, the presence of mental and medical disorder, substance abuse, and advanced age. Or giving USMLE should be added there. Normal age related sleep changes include more frequent walking, decreased total time asleep, and increased napping. Okay. Key facts: sleep hygiene measures. Stimulus control therapy to establish a 24-hour sleep wake cycle. Establish a sleep schedule. Limit caffeine intake. Avoid naps. Take warm baths in the evening. Use the bedroom for sleep and sexual activity only. Exercise early in the day. Employ relaxation techniques. Avoid large meals near bedtime. Primary insomnia affects up to 30% of the general population, causes sleep disturbances that is not attributable to physical and mental conditions. Insomnia is often exacerbated by anxiety, and patients may become preoccupied with getting enough sleep. History and physical examination: patients present now with a history of restorative sleep or difficulty initiating or maintaining sleep that is present at least 3 times per week for 1 month. Treatment here is best initial treatment. Initiate good sleep hygiene measures. Next best treatment, psychotherapy, specifically CBT for insomnia, CBTI. Pharmacotherapy can be initiated with care for short periods of time, less than 2 weeks. Pharmacologic agents include diphenhydramine, zolpidem, zolpidem is Ambien, zelplone, and trazodone. Okay. Um, Primary hypersomnia diagnosis. Diagnosed when a patient complains of excessive daytime sleepiness or nighttime sleep that occurs for more than 1 month. The excessive somnolence cannot be attributable to medical or mental illness, medications, poor sleep hygiene, insufficient sleep, or narcolepsy. Treatment here: best initial treatment, CNS stimulants, amphetamines, and antidepressants such as SSRIs may be useful in some patients. Narcolepsy onset typically occurs by young adulthood, generally before 30 years of age. Some form of narcolepsy may have a genetic component. Diagnosis: manifestations include excessive daytime somnolence and decreased rapid eye movement, sleep latency at least 3 times a week for at least 3 months, hypercretin deficiency, that is important, confirmed by CSF sampling, is also diagnostic for this condition. Sleep attacks are the classic symptoms. Patient cannot avoid falling asleep. Characteristic: excessive sleepiness may be associated with the following: cataplexy, that sudden loss of muscle tone that leads to collapse. Hypnagogic hallucinations. It occurs as the patient is falling asleep. Hypnopompic, okay, hallucination occurs as the patient awakens. So the way you remember this is go for going to sleep. Okay, so occurs as the patient is falling asleep, and pump is waking up, like he's pumped to wake up now in the morning, right? So pumped to waking up in the morning. Hypnopompic hallucination occurs as the patient awakens. Sleep paralysis, brief paralysis upon awakening. Treatment: a regime of scheduled daily naps plus stimulant drugs such as amphetamines or modafinil, SSRIs for cataplexy. Okay. Um, okay. Modafinil is the same drug. Oh yeah, but it's the topical for hair loss, right? And also it helps. Both amphetamines and modafinil helps with the since they are stimulants, ADHD. Okay. Sleep apnea. Sleep apnea occurs secondary to disturbances in breathing during sleep that lead to excessive daytime somnolence and sleep disruption. Etiologies can be either central or peripheral. Central sleep apnea, a condition in which both airflow and respiratory effort cease. CSA is linked to morning headaches, mood changes, and repeated awakening during the night. OSA, or obstructive sleep apnea, a condition in which airflow ceases as a result of obstruction along the respiratory passages. OSA is strongly associated with snoring. Risk factor: male sex, obesity, prior upper airway surgeries, a deviated nasal septum, a large uvula or tongue, and uh, retrognathia, recession of the mandible. In both forms, arousal results in cessation of the apneic event. Sleep apnea is associated with sudden death in infants and older adults, headaches, depression, increase in systolic blood pressure, and pulmonary hypertension. So here, this is the if you're ever confused between if it's obstructive sleep apnea that you're dealing with or something else, they will have increased systolic blood pressure. So it's going to be about 130, 140. Okay. Um, Diagnosis: sleep study, polysomnography to document the number of arousals, occupation, and episodes of decrease in O2 saturation, distinguish OSA from CSA. Okay. Um, right. So that also helps to differentiate between CSA and OSA. So this is again sleep study, pulmonary somnography, uh, polysomnography to document the number of arousals, obstructions, and episodes of reduced O2 saturation. Distinguish OSA from CSA and identify possible movement disorder, seizures, and or other sleep disorders. Okay. Okay, so treatment for OSA, nasal continuous. Okay, hold on. So condition in both airway and respiratory. CSA is linked to morning headaches, mood changes, and repeated awakenings during the night. whereas OSA is the one where there is somnolence, right? Sleeping during daytime, I believe. Okay. So treatment: OSA, nasal continuous positive airway pressure, CPAP, weight loss if obese. In children, most cases are caused by tonsillar adenonodal hypertrophy, which is corrected surgically, and CSA, mechanical ventilation, for example, bilevel PEP, with a backup rate for severe cases, or BiPAP. Okay. The one I'm thinking of, I think that was Pickwick instance that I'm thinking of. Circadian rhythm, uh, sleep disorder, a sleep a spectrum of disorders characterized by a misalignment between desired and actual sleep periods. Subtypes include jet lag, shift work, delayed sleep phase, night owls, advanced sleep phase, early birds, and unspecified causes. Treatment here is jet lag type usually resolves within 2 to 7 days without specific treatment. Shift work and delayed sleep phase type may respond to light therapy. Modafinil is approved for shift work sleep disorder. Oral melatonin may be useful if given 30 minutes before the desired bedtime. Question: a 57-year-old morbidly obese man presents to his physician with concerns about increased daytime sleepiness. Okay, so basically what I was trying to figure out, and decreased work productivity. His wife adds that he has excessive snoring that sounds like the snort of a steam engine. What long term complications are concerned for this patient? So, increase in BP could cause heart, cardiac myopathy, I guess. Let's see. The patient has obstructive sleep apnea. Serious consequences include leg swelling, hypertension, core pulmonale, stroke, and clinical depression. Okay, so leg swelling, hypertension, core pulmonale, uh, stroke, and clinical depression. Okay. For it to be Pickwickinson, they have to mention their BMI, okay, and the BMI has to be above 30. Okay. Moving on to somatic symptoms and related disorder. Okay, these are one of the confusing ones. Uh, but if you know the pattern, then it's one of the easy ones to figure out. Somatic symptom disorder. Patients often present with excessive thoughts, anxiety, and behavior driven by the presence of somatic symptoms that are distressing and negatively affect daily life. Somatic symptom disorder may occur with or without any medical illness present. High health care utilization is often present. Disorder may present with multiple recurrent somatic symptoms that may be specific, for example, localized pain, or non-specific like fatigue. Even normal bodily symptoms can be perceived as unduly threatening even when there is evidence to the contrary. Okay, so treatment here is scheduling regular appointments with one clinician as primary caregiver, avoiding unnecessary diagnostics, but legitimizing symptoms. Psychotherapy focused on reducing psychosocial stressors. Illness anxiety disorder, formerly known as hypochondria, for at least 6 months. Patients have anxiety about and preoccupation with acquiring a serious medical illness despite having no somatic symptoms or mild somatic symptom. A normal physical examination, negative tests, and reassurance from a healthcare provider. The patient's preoccupation with illness is not better explained by another disorder. The in addition to the aforementioned, patients must have one of the following: excessive health behaviors, for example, repeated checking for signs of an illness, or maladaptive avoidance of situations, for example, healthcare settings, visiting sick family members. Okay. So treatment here is CBT, that's first line, another type of psychotherapy, second line, and antidepressant medications, third line. Key fact here is psychogenic non-epileptic spells can co-occur with a seizure disorder. Okay. Conversion or disorder, also known as functional neurologic symptom disorder, characterized by symptoms of um, of okay, characterized by symptoms or deficits of voluntary motor or sensory function, for example, blindness, seizure-like movements, uh, paralysis, incompatible compatible with medical processes, close temporal relationship to stress or intense emotion. Okay. Diagnosis: symptoms unexplained by other medical or neurologic causes, signs during physical examination suggesting non-organic cause of symptoms, presence of Hoover sign, that's extension of affected leg when asked to raise the unaffected uh, contralateral leg when attempting to rule out the leg paralysis. Uh, Eyes closed and resistant to opening during seizure. Negative simulation, simultaneous EEG. Disappearance of tremors with distraction. Labile indifference. That's patients are strangely indifferent to their symptoms, commonly associated but not required for the diagnosis. Okay. Treatment again: psychotherapy, physical therapy, occupational therapy, treating comorbid psychiatric issues, anxiety, uh, depression, and trauma. Goal is improve function. Okay, I believe this was the one where um, mourning a father's death, the daughter started having abdominal pain, and then she didn't care about it though, or like yeah, something like that. Um, okay, fastidious disorder and malingering. Diagnosis: fastidious disorder, formerly known as Munchausen syndrome. There was a good episode on Dr. House about this. Characterized by the fabrication of symptoms or self injury to assume the sick role. Primary gain. Okay. And then there is by proxy. So, fastidious disorder imposed on another, formerly Munchausen by proxy. This is caregiver exaggerates or falsifies medical psychiatric symptoms or intentionally induces illness in someone else to receive benefit by taking on the role of concerned caregiver. Okay, there was a case about this where the mother kept on coming to the hospital with her child, and the doctors would do examinations, and she's always worried what's going on with the child. And whenever they did examination, they always found that the baby had increased amount of salt in her blood, so hypernatremia. um, and then they would keep the child under observation, and then a couple of days it would return to normal, and then like suddenly it would rise again, and they couldn't figure it out what was going on. And then eventually what happened was they went to her house, and then they checked the when they were in the bathroom, they saw like table salts all over the place. So and when they came back, they realized that the mother was feeding salt to the baby while she was inside in the hospital. Why was she doing it? She liked that she was getting attention from the doctors and being concerned and concerned parent and all that. Okay. So malingering. So that was by proxy. So malingering is patients intentionally cause a feign symptoms for secondary gain. For example, financial, housing, legal. Okay. Okay. So here there is they do it because they want some kind of gain from it. Whereas in fastidious disorder, there's no gain other than gaining sympathy type thing. Okay. Treatment: psychotherapy, minimal diagnostic, and treatment to avoid reinforcement or behavior. Uh, Contacting appropriate legal authorities, fastidious disorder imposed on another. Sexual and physical abuse most frequently affects females less than 35 years of age who are experiencing discord, marital discord, and have a personal history of or a partner with substance abuse. Okay. are pregnant. So most frequently affects female less than 35 years of age who are pregnant, have low socioeconomic status, or have obtained a restraining order. Victims of childhood abuse are more likely to become adult victims of abuse. History and physical examination. Uh, Patients typically have multiple somatic complaints, frequent emergency uh, department visits, and unexplained injuries with delayed medical treatment. They may also avoid eye contact or act afraid or hostile. So, somatic again, what was somatic? Patients often present with excessive thought, anxiety, and behavior driven by the presence of somatic symptoms that are distressing and negatively affect daily life. Okay, so that children may exhibit precocious sexual behavior, genital or anal trauma, sexually transmitted disease, UTIs, and or psychiatric behavior problems. See pediatric chapter. Okay. So mostly like if you have like a 4-year-old, 5-year-old who knows, the naughty words, uh, you should consider sexual abuse there. Other clues include a partner who answers questions for the patient or refuses to leave the examination room. Okay. Treatment here is perform a screening assessment of the patient's safety domestically and in their close personal relationship. Provide medical care, emotional support, and counseling. Educate the patient about support services and refer the patient appropriately. Documentation is crucial. Know local laws for reporting suspected child and elder abuse. Key fact here, sexual abusers are usually male and are often known to the victim and are often family members. Okay. Sexual assault. Any sexual act performed on another individual without their consent. Diagnostic evaluation and testing. Assessment for physical injury with focus on genital trauma. Psychological evaluation. Pregnancy test. Testing for sexual transmitted infections. Smear culture for chlamydia uh, and gonorrhea. Wet mount and culture for trichomonas, consideration of testing for HIV, HSV, HBV, syphilis, and CMV. Forensic evaluation with detailed history and sample from buccal, mucosa, vagina, rectum, fingernail scraping and clippings, blood samples, and saliva samples. Okay, so assessment of physical injury and that. So first we do assessment of the physical injury and focus on that. Second, psychological evaluation. Third, pregnancy test. Fourth, testing for sexually transmitted infections. Fifth, forensic evaluation. And then, so in that, important historical details include contraceptive use, last time of coitus, condom use before the assault, drug or alcohol use, history of STDs, description of the assailant, location and time of the assault, circumstances of the assault, for example, penile penetration, use of condoms, extragenital acts, use or display of weapons, and the patient's actions since the assault. For example, douching, bathing, brushing teeth, urination, defecation, changing clothes. Post exposure prophylaxis and evaluation, follow up medical visit within 1 to 2 weeks, ceftriaxone plus azithromycin with or without metronidazole for prophylaxis against gonorrhea and chlamydia, hepatitis B booster vaccination if unknown vaccination and immune status, or if unvaccinated, HIV, antiretroviral drug offered within 72 hours of assault. Options are tenofovir, emcitricitabine, uh, plus raltegravir, human papillomavirus. Vaccination recommended uh, at the time of initial evaluation in female survivors aged 9 to 26 years and male survivors aged 9 to 21 years. Okay, so 9 to 26 and 9 to 21. Contraception. Uh, Emergency contraception, progestin, antagonist, agonist, ulipristal, or levonorgestrel, or combination ethinyl estradiol and levonorgestrel, USP regime, offer for mental health services. Okay. Mnemonic for suicide attempts, said person, sex, male, age, older, depression, previous attempt, greatest risk, ethanol, substance abuse, rational thinking loss, sickness, chronic illness, okay, organized plan, access to weapons, no spouse, and social support lacking. Okay. Um, so account for 45,000 deaths per year in United States, the 10th overall cause of death in the U.S. Approximately one suicide occurs every 11 minutes. Risk factor. Previous suicide attempts, a primary risk factor, that's number one. If they give you a bunch of risk factors and ask you which one's the most, uh, you know, likely one, what's the highest risk factor, then it would be this one first. Previous suicide attempt. Then comes the access to weapons, I believe. Okay. Male sex, more than 45 years of age, psychiatric disorder, MDD, presence of psychotic symptoms, history of psychiatric hospitalization, history of violent behavior, ethanol or substance abuse, recent severe stress, poor social support, and a family history of suicide, CSAD persons. Okay. Mnemonic. Okay. So that, okay. Females are more likely to attempt suicide. Men use more lethal methods like firearm and are more likely to complete suicide. Adults aged 45 to 64 have higher rates of death from suicide than other age groups. However, young adults aged 18 to 25 years are at higher risk for suicidal thoughts and attempts than other age groups. Protective factors, social support, family connectedness, religiosity, uh, pregnancy, and parenthood. Okay. Key fact here is suicide is the second leading cause of death after unintentional injury amongst 15 to 24 years of old in the United States. Key fact: emergent inpatient hospitalization is required for patients with suicidal intention. Diagnosis: perform a comprehensive psychiatric evaluation. Ask about family history, previous attempts, ambivalence towards death, and hopelessness. Ask directly about suicidal ideation, intent, and plan, and look for available means. Treatment: a patient who endorses suicidality requires emergent inpatient hospitalization even against their will. Suicide risk may increase after antidepressant therapy is initiated and is considered an adverse effect of the medication. There is a black box warning on all antidepressant medications when used in those less than 24 years of age. Okay, and that's it. We're done. Uh, Go ahead and do those 300 questions and more on psychiatry now. See you in the next one.